with the uterine conditions. Okay, so first we have is the adenomyosis. Okay, whenever you have the extension of the endometrial tissue, which is the endometrium, of course, whenever you have the extension of endometrium into the myometrium, that means if the endometrial glands are found in the myometrium, you will call it a adenomyosis. Okay, it happens because of the hyperplasia of the basal layer of the endometrium, and that basal layer is basically growing into the myometrium. So when you do the biopsy of the myometrium, you will find the muscle cells, smooth muscle cells, as well as these glands. And that's how you know that this condition is basically the adenomyosis. On the gross examination, you will be having a diffuse enlargement of the uterus. Okay, the uterus will be diffusely enlarged. This condition is very painful, of course. Okay, so you'll be having a uniformly enlarged soft uterus. Okay, and this patient will be having a pain with the menorrhea. Okay, and whenever they have a bleeding, they will have a very pain. So you will have a dysmenorrhea. Okay, you can have a abnormal uterine bleeding. Okay, because of that. So whenever a patient presents you with a painful menses along with a diffusely enlarged uterus, you will think about the adenomyosis. Is that okay?
Yes.
So a painful menses along with a diffusely enlarged uterus, think about the adenomyosis. Treatment again, inhibiting the GnRH, LH, and FSH. So you can give the patient GnRH agonists. Okay. You can also perform the hysterectomy in the patient. Okay. Or adenomyoma could be excised also by the surgery. So these are the methods for the treatment. Okay. Similar to that condition, you also have one condition which is the endometriosis. In the endometriosis, these endometrial glands or endometrial tissue is found to other locations. And it could be anywhere in your body, maybe in the intestines, maybe in the urinary bladder, maybe in the ovary, maybe in the fallopian tube, maybe in the vagina. It could be anywhere. So instead of the uterus, if these tissues are found anywhere else also, you will call it a endometriosis. So endometrium-like glands or stroma that are found outside the endometrial cavity, you will call it an endometriosis. Causes are multiple, okay? And this first could be due to a retrograde blood flow. Okay, whenever at the time of menses, if if instead of going this blood from from the uterus to the vagina to the outside of the body, if this blood go opposite direction, that means into the fallopian tube, right? Then you can have the movement of these glands into the fallopian tube and then into the ovary, right?
Yes.
So due to a retrograde blood flow, you can have, what you call it, the translocation of these glands, these tissue to other parts, right? Into the fallopian tube, into the ovary. Okay, and that will be the cause of the endometriosis. Second cause could be whenever a multipotent cell, that means it could be a stem cell, whenever a stem cell become metaplastic and now it becomes the endometrial-like layer. Okay, so it is a kind of metaplasia in which this stem cell layer of maybe the ovary, fallopian tube, or other areas, urinary bladder, maybe the intestine. Okay, whenever they become metaplastic and they transform into the endometrium-like layer, you will call it again endometriosis. Okay, third thing could be the transportation of this endometrial tissue via the lymphatic system. So it is kind of a metastasis, right? Whenever these tissues travel to the lymphatics, to other areas, to other tissues, they lodge there, and then they form, their endometrium there. They will form the glands there and other these structures, right?
Yeah.
So three things are possible. One is the retrograde menstrual flow. Whenever you have a flow in the opposite direction, you can have this condition. Okay, a coelomic metaplasia could do that. Okay, and a metastatic growth can do that. So these are the three reasons why you are having an endometriosis, why you are having a different, why you are having these tissues in different locations. Okay, now symptoms will be, of course, with each cycle, because they are, because all of these tissues are under the hormone regulations, right? Yes. All of this endometrial tissue will be under the regulation of estrogen, right? These tissue will respond to the estrogen. Yes.
Yes.
So with each cycle, you will have a hyperplasia in these tissues, right? Wherever they are present in the urinary bladder, in the intestine, or anywhere, you will have a hyperplasia with each cycle, right?
Right.
Yeah.
And at the end of each cycle, you will have a bleeding from these tissues.
Yeah.
Yes. So what you will have is a very bleeding. You will have a prolonged menstruation because at multiple sites you have the bleeding, right? Now let us suppose if these tissues dislocated to the ovary, then with each cycle you will have an accumulation of the blood into the ovary, right?
Right.
Yeah.
So this thing will also be, so you will have an accumulation of the blood into the ovary, okay? And you call it a endometrioma, okay? It will be a blood-filled chocolate cyst within the ovary, okay? That thing would be seen, okay? Now, wherever these tissues lodges, you will have, a burnt gunpowder-like lesion. You will have a yellow-brown lesions at that areas. For example, if you perform a cystoscopy and you find these kind of lesions there, endometriosis there, what you will see on the endoscopy, cystoscopy, you will see the gunpowder-like lesions there, yellow, brownish deposits within the bladder. If you perform this endoscopy into the rectum, so what you will find in the endometriosis, the gunpowder-like lesions, or you can say yellow-brown lesions within the rectum, right, or within the intestine, right?
Yes.
So on the appearance, they will appear as a yellow-brown lesions wherever they lodges. Okay. Now, the patient can be having a pelvic pain. With each cycle, cyclic pelvic pain will be present. Prolonged bleeding will be present. Now, if these tissues dislodges to the vagina, then patient will have pain with the sex, right?
Mm-hmm.
Similarly, and you call this condition a dysmenorrhea, right? And whenever these tissues lodges to the intestine, into the colon, you will have a pain with the defecation, right? You will have a bleeding with the defecation.
Yeah.
You will call it a dysphagia, right? You will also get the infertility. Okay. Uterus, please note, will be the normal size because these tissues are not lodges to the myometrium yet. If similarly these tissues lodges to the myometrium, you will call it a adenomyosis, right?
Right.
So in this
Well,
condition, yeah.
well, I mean, if it's in the uterus, then would it not just flow out?
Sorry, I didn't understand.
You're saying that the normal uterus, it's not settling there, but isn't that because that's where it's supposed to be? Like that's where the bleeding is supposed to be, so it's going to be.
In the uterus, it's supposed to be in the endometrial layer, right? But if the endometrium embedded in the myometrium, then it will cause the problem, right? Because
Oh,
myometrium won't shed. It is the
yeah.
endometrium that sheds, right?
Yeah, thank you.
So that will stay there forever, and you will have a bleeding things. You will have a this increase in the size of the uterus uniformly, right? So if these tissues lodges in the myometrium, you will call it is adenomyosis, right? And if the lodges anywhere else, you will call it a endometriosis. Okay.
Okay.
So now the pelvic pain, or you can say the abdominal cramps, will always begin 1 to 2 days before the menses. Patient will have a very painful bleeding. A prolonged bleeding will be there. And if the tissues lodges in the vagina, patient can have a pain with the sex. If these tissues lodges in the when the colon, and then you can have a pain with the defecation. Similarly, if these tissues lodges in the in the urinary bladder, then you can have a pain with the micturition, right? So wherever these organs lies, these tissues, the lodges, you will have a pain accordingly with that condition. Yes.
Yeah.
Now, again, important thing is when you perform the examination on this patient, what you will find is the retroverted uterus. Okay, so normally see, if this is the cervix and the vagina, okay, then you have a uterus like that, right? This is the placement of the uterus, right? Anteriorly. Okay.
Yeah.
But in this condition, instead of the anteriorly, the uterus will become like that, posteriorly or flattened like that. Okay. You will call it a retroverted uterus. Normally, you have the anteverted uterus. In this condition specifically, you will get a retroverted uterus. Is that okay?
Okay.
So that thing, yeah.
Isn't the uterus supposed to be retroverted?
No. Anteverted.
Oh,
Normally, you have the uterus like that. The angle between the uterus and the cervix is like that, right?
mm-hmm.
But in this condition, the uterus and the cervix become like flattened in a single line, 180 degree to each other, right?
Okay, I understand.
So this is what you will see in the retroverted uterus. Okay.
Thank you.
So the pelvic pain, bleeding, dysmenorrhea, or maybe the painful menses, dyspanuria, dysphagia, right? Dysphagia you will have, infertility, normal size uterus, but retroverted uterus you will see. Okay, infertility is a very important thing. Okay, and the causes are also important. Retrograde flow, this flow could be there, metaplastic transformation could be there, or the metastatic movement could be there of the cells, right, via lymphatic system. So that all causes the endometriosis. Treatment again include the NSAIDs for the pain control, OCPs to control the growth of these tissues, progesterones could be given, GnRH agonist could be given, danazol could be given, and laparoscopic removal of these tissues should be done. If they're in the rectum, if they're in the urinary bladder, in the fallopian tube, in the ovary, in the vagina, they will be removed by the laparoscopic surgery. Okay, so that is a treatment of the patient. So if you encounter a patient having a very blood-filled ovary, okay, having a cyclic abdominal pain, heavy menses, always think about the endometriosis. And because these lesions are yellowish brownish, so whenever you see the ovary, this endometrium, you will have a blood-filled chocolate-colored ovary, very dark-colored blood-filled there, right?
Right.
Let me share you the picture if there is available. Just give me a second. Yeah, this kind of a thing you will see on the ovaries, right? As you can see, these are filled with the blood, right? Which is chocolate colored, literally chocolate colored, right?
Yes.
Okay, that is the condition you will see. And that's all about that. And as you can see, these are the gunpowder-like lesions you will see on the endoscopy of the patient, or maybe the cystoscopy of the patient, right?
Yeah.
Okay. Now, any doubt on the endometriosis?
No, thank you.
Okay. Now you have the Asherman syndrome. Okay. With the dilation in curettage, okay, with the examination of the patient, if you perform the dilation in the curettage very aggressively, in that case, you can damage the endometrium layer of the patient. And if the stem cells are gone while doing that, you will have a scarring in the uterus, right?
Right.
Now, if the endometrium layer is gone, then you will have a loss of fertility also.
Yes.
Because you need the endometrium for that, right? For the placenta placement, you will need the endometrium, right? If the endometrium is not there, you won't get the fertility, right?
Right.
So this condition occurs with the dilation and the curettage of the intrauterine cavity when you do it very aggressively. That causes a damage in the stem cell layer of the endometrium. And as a result, the patient will get the fibrosis of the endometrium. Patient will have a loss of fertility. Recurrent pregnancy losses will be there. Okay. Abnormal uterine bleeding could be there, and pelvic pain could be there. And that's all about the Asherman syndrome. Okay.
Yeah.
So any doubt in the Asherman syndrome? It would always be a patient who recently underwent for examination, or maybe for a MTP maybe. Okay, so after the MTP, you need to remove the fetal tissue, right? All the tissue of conception, you remove that, right? So while doing that, if you do that aggressively, patient can have this this Asherman syndrome, and patient will lose the fertility. So they will always have a history of some kind of examination, some kind of an MTP, and after that the patient become infertile, right? So that's how these patients will present you with, and that's how we diagnose this condition. Okay.
Yeah.
Give me a second. Now you also know about a progesterone challenge, right? Progesterone challenge. You will see that in the pharmacology section, a progestin challenge is there in which you give the patient a progesterone pill. Okay. After you remove that pill, if you got a bleeding, that means it could be due to any other cause. But even after the removing of this pill, okay, if the patient does not got the bleeding, you will diagnose the patient with the Asherman syndrome. Okay. And that is known as the progestin challenge.
Okay.
You give the patient progesterone hormones, okay, and then you remove them after that, right? After a week or after 10 days later, whenever you encounter a patient having a recurrent pregnancy losses or maybe the infertility or maybe, no menses, in that case, you will give the patient progesterone for a week or maybe 10 days. After that, if the patient got a withdrawal bleeding, that means this condition is totally normal, okay? If the patient does not get the bleeding, then you will diagnose them with the Asherman syndrome, because that means it is a anatomical defect, right?
Right.
So even if you remove the progesterones, you won't get the bleeding, and that means something is wrong with the endometrium. That means the patient might be having the Asherman syndrome. So remember this test, the progestin challenge, okay? You will use that for the Asherman syndrome. Now any doubt, please ask.
No, thank you.
Okay, now you have the endometrial hyperplasia. Okay, and that always happens whenever you have a high estrogens, right?
Right.
So by any means, if you expose to a high dose of estrogen, it could be due to a cancer, it could be due to an exogenous, implantation. It could be due to any cause. If you got an exogenous or maybe endogenous, the estrogens, high level of them, you will get this hyperplasia of the endometrium. And whenever you get a hyperplasia of the endometrium, you will be at an increased risk of getting an endometrial cancer also, right?
Yeah.
Now, these patients will be having a post-menopausal vaginal bleeding. It will be a patient who is more than 55 years of age. She's in the post-menopausal this period. Even after that, the patient started having these bleeding complications, right? And that's how you will know that the patient could be having an endometrial hyperplasia. So whenever you encounter old age patients having a bleeding from their vagina, you will think about the endometrial hyperplasia. Okay, patients will be having an increased risk with the anovulatory cycles, because whenever you have a anovulation, you won't have the progesterone phase, right? Because only after the ovulation you can have a corpus luteum formation, then only you can have a progesterones, right?
Right.
So if the patient have an anovulatory cycles, that means at that time you won't get any ovulation, then you will be exposed to estrogens only, no progesterones, right?
Yeah.
So unopposed estrogen will causes the endometrial hyperplasia again, right? If the patient got a hormone replacement therapy, then they can have this endometrial hyperplasia also. PCOS, I told you in the PCOS, because of the high this estrogen, you can have the endometrial hyperplasia also, and that will increase the risk of cancer again, right?
Yeah.
Any tumors of the granulosa cells or maybe a thicoma can do that,
Yes.
right? So exogenous or endogenous, any condition which increases the estrogen levels in the body, that can lead to the endometrial hyperplasia. And because of that hyperplasia, you will get an abnormal uterine bleeding. It could be a post-menopausal vaginal bleeding in the patient. Okay, and the patient will be at an increased risk of getting the endometrial cancer. Okay, so that's all about it. Any doubt, please ask.
No, thank you.
Okay, now you have the endometritis. And itis, that means it is an inflammatory condition. And endometritis is little the inflammation of the endometrium. Now you guys already know one cause of the endometritis, which is in the macrobiology we discussed.
PID.
The PIDs, yes. And the pelvic inflammatory diseases, that includes the endometritis also, right? Endometritis, salpingitis, right?
Right.
So endometritis, the one cause is of course the gonorrhea or the chlamydia. Now, other important cause includes whenever you have a retained products of the conception, could be a placental tissue, could be a fetal tissue, could be anything. Okay, if the cleaning is not properly done and you have a retain of this conception tissue, then that will act as a nidus for the bacterial growth. Okay, and that will cause a bacterial overgrowth in the uterus, in the endometrium, and that will lead to the inflammation of the endometrium. That means the endometritis. So most of the times, the patient will present you with this abdominal pain, fever, bleedings, okay, and maybe a discharge from the vagina, of course, you will get, okay, and that happens shortly after after delivery or maybe after an MTP, okay, and that's how you know that the patient might be having a retained products of conception, okay. So that will act as an inducer for the bacterial inflammation, and that will cause the endometritis. This thing can also be happen after a STD. Okay, if the patient got a STD, if this patient got a gonorrhea infection or maybe a chlamydia infection, that can again lead to the endometritis, right? The patient will have a history of discharge, pelvic pain will be there, fever will be there, right?
Yeah.
So these kind of things will be present in the endometritis. Now, when you perform the biopsy of the patient, if it is a chronic endometritis, you will find the lymphocytes there, right? Which are the hallmark of the of this inflammation, chronic inflammation. Remember, general pathology.
Yeah.
Hallmark feature of chronic inflammation, lymphocytes, plasma cells. Remember.
Yeah.
Yeah.
So if the patient is having a chronic the chronic endometritis, what you will see is the plasma cells on the histology. Okay, and if the patient is having an acute endometritis, you will see the neutrophils there, right?
Right.
Now, the acute causes, the bacteria that causes this acute condition, acute endometritis, shortly after the pregnancy or after this, this abortion or maybe anything, it will be the Staphylococcus aureus. Okay, and the cause for a chronic type will be the gram-negative bacillus like the chlamydia and like the gonorrhea. Okay.
Okay.
So mostly whenever you encounter a patient who is having a recent history of delivery or MTP or maybe the intrauterine devices, now she is having an acute abdominal pain, fever, discharge, bleeding, right? You will always think about the Staph aureus induced endometritis. Okay, when the patient is not having such history, just a STD case it could be, you will think about the gonorrhea or could be the chlamydia. Okay.
Okay. Yeah.
Now, tuberculosis can also do that condition because I told you whenever you have a disseminated tuberculosis, it can go anywhere, right? It can go to the bones, it can go to the brain, it can go to the vagina, it can go to the uterus, it can go to this bladder, it can go to the lungs, it could go anywhere, right, in your body.
Right.
So again, shortly after tuberculosis, patient can also have endometritis. So most importantly, it would be a immigrant case, right?
Yes.
It would be immigrant patient, okay, who is from any Asian country or maybe not vaccinated, okay, or maybe in a jail patient, a patient from a jail maybe, right? And now they're having this endometritis. You will perform the lung examination. You find this calcified nodules in the lungs, okay, and that's how you know that this endometritis is caused by the tuberculosis. Now, after this endometritis, if this stem cell layer got damaged because of the inflammation, you will have a scarring, right, in the endometrium.
Right.
If you got a scarring, then you will have be at an increased risk of getting the infertility, or maybe remember the morbidly adherent placenta. I told you scarring is our risk factor for that.
Yeah. Yeah.
So a morbidly adherent placenta is a complication. Infertility is a complication again, right? And if it is a case of PID, then it can also lead to the ectopic pregnancy, right?
Right.
So that's all the complications of this disease, endometritis. Now, any doubt, please ask.
No, thank you.
Now, depending upon what bacteria could be causing it, you could given the patient gentamicin with clindamycin with or without the ampicillin. Okay, and if it is a case caused by the PID, then you have to give the patient ceftriaxone along with
Azithromycin.
erythromycin. Yes. So that's about the treatment of the patient. And that's all about the endometritis. And please note, because it is a bacterial inflammation, it is a bacterial infection, you will always get a purulent discharge. Okay, a bloody or maybe a purulent discharge you will get from the vagina. Okay.
Yes.
Okay, so I've covered all these non-neoplastic uterine conditions. Any doubt on these conditions? Any of them? Please ask. Or anything you want me to repeat it again?
For the endometrial hyperplasia, is it that the people who have anovulatory cycles, PCOS, and hormone replacement, are they most likely to have the postmenopausal vaginal bleeding, or are these all various causes?
See, let us suppose it would be a postmenopausal female. How would she get this condition? She won't have eggs, right? She won't have
Yeah.
these follicles, right?
Mhm.
So how will she get the condition?
Something is causing her to have excessive estrogen production.
And how it could be in a postmenopausal female?
Estrogen replacement therapy.
Okay, one thing it could be, yes. Or any endogenous cause?
If she were to have endometrial cancer,
Okay, cancer could do that. And if there is no cancer, then
GnRH production,
see what kind of a estrogen is predominant in the postmenopausal females?
estrium
Estrogen. And how does it form?
from fat.
From fat, exactly. If this is a fatty female, okay, postmenopausal fatty female, can she have a high level of estrogen in her?
Okay, I understand. Yeah.
And that can again lead to the endometrial hyperplasia, right?
Yes.
So a obese postmenopausal female could have this condition. Yes.
Mm-hmm. I
Okay.
understand.
Any more doubt?
No, that's good.
Okay. Then you have the neoplastic conditions in the uterus. Okay. The first one is the endometrial carcinoma. Any cause which is causing an endometrial hyperplasia, you can have a carcinoma after that, right? Because hyperplasia always causes a carcinoma. General pathology part, remember?
Yeah.
Every hyperplasia, every metaplasia, every dysplasia will lead to the cancer ultimately, right?
Yes.
And does anyone remember one hyperplasia which does not cause cancer?
Benign prostatic, BPH.
Yeah, the BPH. Yes, exactly, BPH. Except the BPH, every other hyperplasia can cause a cancer, right? So the most common symptom of this endometrial cancer is the irregular vaginal bleedings you will get. Okay, it could be due to two types. One is the endometrioid type, and second is the serous type. Serous type will happen in the postmenopausal women, okay, and that is associated with the endometrial this atrophy, okay. And importantly, in the serous type, you will find the samoma bodies. So in a postmenopausal female, if you perform the biopsy of the endometrium and you find the samoma bodies there, what you will find is the serous type of endometrial carcinoma. Second is the endometrioid type that happens in the obese patients mostly due to the unexposed estrogen exposure. Okay, these patients will have an early menarche, okay, and late menopause. Even after the 55 years of age, they won't have the menopause. They still have the bleeding up to 60, 62 years. That's how you know this condition could be an endometrial carcinoma. If the patient suddenly got a normal periods again back, okay, after the menopause, you know that this condition could be due to a serious endometrial carcinoma. Okay, if the patient is a nulliparous woman, that means she do not have any child so far. Okay, these kind of patients will be at an increased risk of getting the endometrial carcinoma because they will be exposed to a high level of estrogens, right?
Mm-hmm.
Right.
So these patients could get this cancer again. Okay. On the histology, you will see the abnormally arranged endometrial glands. Of course, you perform the biopsy of the patient. On the endometrium, you will find multiple endometrial glands, which are not like in a normal this tissue, right? And they will be abnormally arranged totally. Okay. Now, patient can also have a P10 mutations. And does anyone remember what other kind of cancers you will get with this P10 mutations?
Prostate, breast, endometrium.
Yeah, the prostate, breast, and the endometrium cancer. These three cancers you will get with the P10 mutations. Okay. And PCOS patients can have that. So any conditions, in any of the conditions, when the patient is having a high level of estrogen, that means endometrial hyperplasia, patient can get an endometrial cancer also. Okay. Two types, endometrioid type and the serous type. Endometrioid type seen in the premenopausal patients, right? That means a reproductive age females. And the serous type of cancer will be also seen, will only be seen in the postmenopausal women, right? In the serous type, you will be having a samoma bodies. Okay, and the endometrioid type, you will be having a just the glands abnormally arranged. Okay, and because it is seen in the reproductive age females, the patient can also have a early menarche or maybe a late menopause. Patient can have a history of nulliparity. Because of that, you will have an increased exposure to the estrogens that can again cause the endometrial carcinoma. Okay, so that was about the endometrial cancer. Any doubt?
No, thank you.
Okay. Now you have, after the endometrium, you have the myometrium, which contains the smooth muscles. Cancer can arise from the smooth muscles also. You will call it a leiomyoma or the leiomyomosarcoma. If it is a benign condition, if it is a benign cancer, you will call it a leiomyoma. If it is a cancerous or a metastatic condition, you will call it a leiomyosarcoma. And please note that the leiomyoma is the most common tumors in the females. It's the most common type of tumor found in the females. Okay. What you will have, this could arise from multiple locations. Okay. It could be subendometrial. Okay. Let me just give me a second. Yeah. So it could be, subepithelial type, which is present just below the endometrium. It could be intramural, which is present inside the muscle layers, or it could be a subserosal. So if I draw this is a uterus, okay? This is the endometrium, okay? And this is the serosa, okay? This whole layer from here to here is your myometrium, okay? Now this tumor can arise just below the endometrium. You will call it a subepithelial type, okay? Like that, you will have this kind of a tumor, okay? This tumor can arise within the muscle cell completely, okay? You will call it a intramural type, okay? And this tumor can also arise just below the serosa. You will call it a subserosal, okay?
Yeah.
So no matter how, no matter from where you got the cancer, from which side you got the cancer, you will always have a irregular enlargement of the uterus, right?
Yeah.
Right.
As you can see, the uterus is normal here, but then it suddenly enlarges at here and then get normal at here, right? So irregular kind of enlargement will be seen. Yes.
Right.
Now, similar to the condition in the adenomyosis, you will be having an enlargement of the uterus also, right?
Yes.
But in case of adenomyosis, it will be a diffuse uniform enlargement. And in case of my leiomyoma, it will be the irregular kind of enlargement. So whenever you encounter a patient, whenever a CV is saying that the patient is having a regular or a diffuse enlargement with the pain, that means it is adenomyosis. If the CV tells you that the patient is having a irregular enlargement of the uterus, you will always think about the leiomyoma. Okay.
Yes.
Now, as you can see, on the anterior side, I have the bladder. On the posterior side, I'm having the rectum, right?
Right.
And because it is a mass, so the patient can be having a mass symptoms, right?
Yeah.
Now, if the patient is having a subserosal tumor, then she will have the symptoms more as compared to all the tumors which are, this subepithelial or maybe the intramural. As you can see, these masses are not growing so much, right?
Right.
So the mass symptoms will be more profound whenever the cancer is subserosal.
Yeah.
Now, if the tumor is subepithelial, then this tumor can project into the cavity of the uterus,
Yes.
right? It can even totally block the cavity of the uterus also if it grows too much, right? And if it blocks the cavity of the uterus, can patient have bleeding? Can patient have menses?
No.
Can patient have the fertilization of the sperms and the ovum?
No.
So the patient will have what is the infertility. Now, this thing can also bleed, right? I told you, remember the palm coin? Any kind of a projection inside the uterus can lead to the bleeding.
Yes.
So because it is again a projection inside the uterus, this thing can bleed. Patient can have an abnormal uterine bleeding also.
Yeah.
So when the bleeding symptoms are profound, you will know that the patient is having a subepithelial type of leiomyoma. When the mass symptoms are profound, it could be obstruction in the passage of the, in the defecation could be there. It could be a case of constipation. It could be a case of pain in the abdomen because of this mass. Okay. and it could be a heaviness in the abdomen, right? And it could be, the micturition, involuntary micturition could be there, right? Because if this tumor, for example, let us suppose is a uterus, so this is a urinary bladder, and this is a uterus, for example. If this tumor compresses a urinary bladder, it will cause an increased load of pressure on the uterus, on this bladder, right?
Yeah.
So the patient, if there is slight increase in the pressure is there, the patient can have a incontinence also.
So that would be stress incontinence.
Exactly, stress incontinence could be there, right? So if the mass symptoms are there, like the constipation, like the stress incontinence, or maybe a heaviness in the pelvic region, or maybe abdominal pain, or you can even find and you can even feel the mass on this abdomen while palpation, right? Then you will know that this tumor will be superficial, right? That means this tumor would be the subserosal type tumor, right?
Yes.
So if the mass symptoms are profound, that means a tumor is subserosal. If the bleeding symptoms are profound, infertility, bleeding, amenorrhea, dysmenorrhea, then you will know that the tumor is subepithelial, right?
Right.
So that's how you know the location of the tumor in the uterus. Now let's discuss. So it is the most common tumor in the females, often present with a discrete tumors, increased incidence. And please note, the incidence will be increased in the African Americans. Step 1 can ask you this. I have a question in the UWorld, I think. And they will ask you, why this patient is having a leiomyoma. Okay, this African patient is having a leiomyoma. So because it is the genetic predisposition is present, right? All these these Americans will be at an increased risk of getting this cancer. It is a benign tumor of the smooth muscles. Okay, and this tumor is again estrogen sensitive. So with each cycle, the size of this tumor will increase, and then again regress, and again it will increase, right? So a cyclic changes will be present. Now with the pregnancy, okay, the size of the tumor will increase because of high estrogen. After the menopause, this tumor will be spontaneously regress because this tumor won't have estrogen after that, right?
Right.
So please note the size of the tumor will increase with each cycle as well as with the pregnancy, and the size of tumor will decrease after the menopause. This tumor is found in the premenopausal females, or you can say a reproductive age females. A most common tumor in the reproductive age females, it is the leiomyoma. Okay, condition could be asymptomatic. It could present with the abnormal uterine bleeding if it is a subepithelial type. It can also result in the miscarriage if it is again a subepithelial type. Severe bleeding can also happen, and when the severe bleeding happens, that can lead to the iron deficiency anemia. Again, happens with the subepithelial type, right?
Yes.
Whenever the subserosal is there, okay, you will have a more irregularity in the size of the uterus. You will have more mass symptoms, okay, like the constipation, bloatings, pelvic pressure, and other things, right?
Right.
Now, once you encounter such patients, you will perform the biopsy of these lesions. And on the biopsy, what you will find are the smooth muscles. Okay, you will, as you can see, these are the word-like appearance. These are the whorls, right? This word-like appearance of these smooth muscles will be seen, and that's how you know that this tumor is a smooth muscle cell tumor. That means it is a leiomyoma. Okay.
Yeah.
So that's about the leiomyoma. And again, if the constipation symptoms are there, that means the tumor is subserosal with posterior location. If the incontinence is there, that means the tumor is anteriorly located, right?
Yes.
So again, they can ask you about the location, which is, if this tumor is anterior, of this tumor is posterior, whether it is subserosal, whether it is intramural, whether it is a subepithelial. So based on the symptoms, you will find about this tumor. Now, any doubt, please ask.
No, thank you.
And yeah, one more thing, please note, because it is a benign tumor, you won't have more mitotic figures. You won't have, this high NC ratio. You won't have this, change in the cells polarity and other things, right? Which is exactly we'll find in the cancers, right? The metastatic cancers. So no features of the metastatic cancer will be present in these types. Okay.
Okay.
Now, if you encounter same patient, okay, but once you've taken the biopsy, what you will see are the numerous mitotic figures, a high NC ratio, nuclear atypia, loss of polarity of the cells. What you will call it a leiomyosarcoma, because you know this tumor is having all the features of a malignant tumor, right?
Right.
So that's how you know that this tumor is not a leiomyoma, but a leiomyosarcoma. And please note, this leiomyoma can never be progressed to the leiomyosarcoma. Okay, this condition is totally 100% benign. Okay, this is a separate tumor. Okay, it always form like that only. Okay, leiomyosarcoma. So it is a malignant proliferation of the smooth muscles that arise from the myometrium. It is always arises de novo, not from the leiomyomas. Always seen in the postmenopausal women, not in the premenopausals. Okay, patient will be having, on the cross examination, patient will be having areas of necrosis and the hemorrhage. And on the biopsy, what you will find are the nuclear atypia and the abundant mitotic figures, which is exactly not seen in the leiomyoma. Leiomyoma are diffusely enlarged like that, without any hemorrhage, without any necrosis, which is exactly opposite you will find in the leiomyosarcoma, right?
Right.
So that's about the leiomyoma and the leiomyosarcoma. Now, any doubt, please ask.
No, that's okay. Thanks.
So that's about all these uterine conditions. Any doubt anywhere on this page?
No.
Sorry, I got a network problem. Can I just get a little difference between leiomyoma and leiomyosarcoma?
A difference again?
Just a point across.
See, on the gross examination in the leiomyosarcoma, you will find the hemorrhage necrosis and necrotic hemorrhagic mass. Okay. On the leiomyoma, it won't be necrotized. It won't be a hemorrhagic mass. It will be a uniformly appearance will be there, right? A capsulated mass will be seen. On the biopsy, if you find a nuclear atypia, numerous mitotic figures, high NC ratio, that means all the features of a metastatic cancer, you will know that this cancer is a leiomyosarcoma. However, if you find a very slight mitotic figures, a very low NC ratio, okay, no nuclear atypia, that means this condition is a totally benign condition. That means it is a leiomyoma. So just based on the histology and based on the cross examination, you will know whether it is a malignant tumor or whether it is a benign tumor. Symptoms will be same for both of these cancer. Okay.
Okay.
Yeah. Now you have the anovulatory cycles, and like I told you, anovulatory cycles will increases the risk of
Endometrial cancer.
endometrial cancer, endometrial hyperplasia. Now this condition is mostly seen in the adolescents, because in the adolescents the HPO axis is still not matured, right? It it recently started yet, right? So it is not yet matured, and as a result, sometimes they have the cycle, sometimes they won't have the cycles. Okay, sometimes they have the ovulation, sometimes they skip the ovulation, and that causes the anovulatory cycles, and that condition is totally normal. Eventually, when the HPO axis got matured, they will have a regular cycles. Okay.
Doctor, till what age we can say that it's accepted in adolescents?
Yeah.
Till what age we can say that an ovulatory cycle
17,
is
18
accepted?
years. 17, 18
Sorry?
years. 17, 18 years. Okay. Up to
Okay.
the 18 years, it is totally normal. Okay. Now, when the ovulation does not occur, patient won't get the corpus luteum. That means no progesterone, and as a result, high level of estrogens would be there that will cause the endometrium to be remain in the proliferative phase, right?
Yes.
Now, let us suppose, let me draw a graph for you. See, let us suppose this is one cycle, this is the second cycle, and this is the third cycle. Let us suppose in one cycle, you won't get the ovulation. Okay. And as a result, you will get the endometrial hyperplasia, right? Let us suppose the endometrial grows like that, this much. Okay. Now, in this second cycle again, you won't get the ovulation, for example. You will again get the endometrial hyperplasia, right?
Yeah.
Again, in the third cycle, you won't get the ovulation. Again, your endometrium will be in the proliferative phase. Again, it will get the hyperplasia, right?
Right.
The size of this endometrium is increased too much. And let us suppose Now you get the ovulation. If you got the ovulation, you will get a complete cycle. You will get the bleeding also.
Yeah.
In a normal patient, when the endometrial size is this much only, they will get a normal bleeding. But in this patient who is having an ovulations, the size of the endometrium is double, triple, right?
Right.
So whenever they get the menstruation, they will get a very heavy menses flow, right?
Yeah.
So either they don't get the ovulation at all, they won't get any bleeding at all. But once they got the bleeding after 3-4 months, it would be a very severe bleeding. Okay.
Right.
So the females will miss the periods, only a spotting will occur. Okay, and when the menstruation occurs, it will last for a much longer period than what is normal. And they also have a heavy menstrual flow. Okay, that's how these patients will present you. They have a irregular cycles. Cycles will occur after each 3 or 4 months. Okay, and whenever they got the cycle, they will have very severe menses. They will have a prolonged flow. Okay, in between that time, in between these 4 months, the patient will have a occasional spotting only. Okay, that's how the patient with the anovulatory cycles will present you. Is that okay?
Yeah.
Okay. So the drugs of the gynecomastia we'll discuss later. Okay, we will encounter this part later. So let's discuss the breast pathologies. Okay, so first we have the terminal duct lobular unit, the TDLU. Okay, and these are the lobules, you can say, and each lobule has a separate duct. Okay, each lobule, each gland has a separate duct. You will call it a TDLU, terminal duct lobular unit. Okay, in between these two lobules, in between the two ducts, you will have some stroma, some tissue is there present, right? Just like any other tissues, you will have a stroma here also. Okay, you will call it a stromal tissue. And all of these ducts, they finally enter into the major duct, and that major duct finally enters into the lactiferous duct, and this lactiferous duct or sinus will ultimately open at the nipple. Okay,
Yes.
that's how the breast is organized. Now you can have a tumor origination from any of these tissues, from the stroma. You can have a tumor origination from the TDLU. You can have a tumor origination from the lactiferous duct, from the major duct. You can have an origination of tumor or any other disease. Okay, the first one is the fibrocystic changes. Okay, and these changes originates from the TDLU. As the name suggests, you will be having a fibrosis as well as cyst formation in the breast. Okay,
Yeah.
and this is the most common condition in the premenopausal woman. The patient will have a breast lumps. They will have a pain in the breast. Okay, this condition could be bilateral. Okay, and this condition is of course multifocal. You will have multiple masses within the breast. Okay, multiple lumps, multiple irregular lumps. Please note the these findings. The patient will be having a irregular breast lumps at multiple locations. Okay, and the patient will also have a cyclic breast pain because all of these lumps, all of these cysts will respond to the estrogen, right?
Yeah.
So when they respond to the estrogen, with each cycle they grows again, and whenever they grows, patient will have a cyclic breast pain. Okay, these lesions, they could be a fluid filled cyst. Okay, and they will appear as a blue dome. Okay, on the examination they will appear as a blue dome. Okay, sometimes metaplasia could be there. Okay, and you could have a apocrine metaplasia, and I told you every metaplasia can lead to the cancer except one metaplasia, remember?
Yeah.
And that is the apocrine metaplasia, right?
Yes.
Yes. So this condition can never progress to the cancer if you have the apocrine metaplasia only. Okay, then you can never progress to the cancer. Okay, so that is about the cystic changes you will get. You will have a multiple cyst formation from these TDLU. These lobules, they will convert it into the cyst. At multiple location, you will have a cyst formation that will cause a cyclic breast pain as well as the breast masses at at multiple locations. Irregular breast lumps will be there. Apart from these cyst formations, patient will also have the stromal fibrosis, and that's why the name fibrocystic changes. You will have a stromal connective tissue which is increased. You will be having an increased collagen deposition on these stromal areas. Okay, and you will be having a cyst formation from the ducts, from the lobules. Okay, multiple cysts will be there which are surrounded by the fibrosis. That exactly what you will see in the microscopy. So cyst and fibrosis will be seen on the microscopy. On the gross examination, irregular masses at multiple locations with the breast pain. Okay, now chances of the cancer usually does not increase, but if you get a sclerosing adenosis, okay, as a name suggests, you'll be having a sclerosis of the glands. Okay, you will have a ascites and the stromal fibrosis. Calcifications will be there, and that will increase the risk of cancer. If the epithelial hyperplasia will occur, then every hyperplasia can lead to the cancer, right?
Yeah.
So along with these fibrocystic changes, if you get epithelial hyperplasia, this will increase the risk of cancer. Although this condition is totally benign, it is normal. Of course, it is the most common condition in these premenopausal women. Okay, this condition is totally benign. But if you have a sclerosing adenosis, that means a sclerosis of these glands, fibrosis of these glands. If you have a epithelial hyperplasia of the TDLU, in that case, that can lead to the cancers. Okay, if just the fibrocystic changes are present, that would increase the risk of cancer. Any doubt?
No, thank you.
Okay, then you have the inflammatory processes. Okay, and the inflammation of this breast is known as the mastitis. Okay, whenever you have an inflammation in the breast, you will call it a mastitis. Okay, now you can have a fat necrosis in the breast because you know the breast, this breast is rich in the fat tissue, right?
Yeah.
So due to yeah, asking something.
No, it's okay.
Okay, so because the breast is rich in the fatty tissue, because of any trauma, patient can have a fat necrosis in the breast. Okay, and please note this condition is totally asymptomatic most of the times. Patient won't even remember if they have any trauma history or not. Okay, it could be a patient who is who is having a history of a very slight trauma could be there, just like a ball. Okay, a trauma from a normal ball could be there. Okay, so they say they don't always give you a history of any kind of a trauma. Okay, it could be asymptomatic condition also. So, okay, the most of the time. Okay, so when you perform the mammography, because whenever the fat necrosis is there, you will always have a dystrophic calcifications, right?
Right.
So when you perform the mammography, you will find the calcified cysts on the mammography. Okay, and that's how you know that a patient could be having a fat necrosis. Now, on the mammography, if you find the calcifications, that would always signifies a cancer. Okay, you will study later that you will always perform the mammography in order to screen for a cancer. And in the mammography, if you find the calcifications, that it means a high chances are there that this patient could be having a cancer. Okay,
Yeah.
but you also know that the breast cancers, most of the time, almost 90% of the times, if there's no family history, then the breast cancer are always found in the postmenopausal females, right?
Right.
So if you encounter a patient who is premenopausal, still in the reproductive cycles, and now she is having a calcifications in the breast, then you won't say that this could be having a cancer. This patient are a very high chance that this patient will be having a fat necrosis instead of cancer, right?
Right.
For the confirmation, you can perform the biopsy. On the biopsy, you will find the giant cells, you will find the necrotic fat. Okay, so yeah, that was about the fat necrosis. So if you encounter a premenopausal woman having a mammography positive for the calcification, you will first think about the fat necrosis. If you encounter a postmenopausal female having a history of calcifications on the mammography, then you will think about the cancer first. Okay, so demographics are very important. Any doubt?
No.
No, thank you.
And most of the time, it could be an athletic patient. It could be a patient on the driving, because while driving due to a seat belts, patient can have a slight trauma that can lead to the injury. Okay, so most of the time they won't give you any kind of a history, but if they give you, they could be an athlete, they could be a basketball player. Okay, they could be a driver or something like that. Okay, now other inflammatory conditions is an infection, that is the lactational mastitis that occurs during the breastfeeding. Okay, now when the baby suck the nipple, they could cause a crack in the nipples, and through these cracks, you will have an infection of the bacteria. The bacteria can enter through these cracks. And because you know that the most common bacteria on the skin is Staphylococcus aureus, right?
Right.
I mean, the most common is, of course, is just give me a second. Epidermidis is the most common, right? But in terms of infection, the most common cause is this aureus, right?
Yeah.
So you can have a Staphylococcus aureus infection in the breast, and that can lead to lactational mastitis. Always occurs at the time of breastfeeding, okay, because of the cracks formation, okay, and through these cracks, the bacteria can gain the access. Okay, so treatment step 1 will ask you what could be you given to the treatment, what about the breastfeeding. So please note that the breastfeeding must be continued. Okay, no need to stop the breastfeeding. And because it is a bacterial infection, you will give the patient antibiotics. Okay, so
Yeah.
it could be a patient having a slight pain in the breast, having a purulent discharge from the breast, having a fever also. Okay, that's how you will know that the patient could be having a mastitis. And if the patient is positive for the mastitis, then you will advise her to continue the breastfeeding. It won't harm the baby, okay, and it will help the patient for the speed recovery. And again, the antibiotics will help. Please note that Staphylococcus aureus is the most common pathogen in case of lactational mastitis. Any doubt, please ask about these inflammatory processes?
No, it's okay.
Okay. Now you're having a benign tumors. Okay, these are the fibroadenoma, intraductal papilloma, and the phyllodes tumor. Okay, the fibroadenoma arises from this stroma and the TDLU. Okay, intraductal papilloma, as the name suggests, it arises from the ducts. Okay, and the phyllodes tumor is just like the fibroadenoma, but a very large type and leafy appearances. We'll discuss that. So the fibroadenoma is the most common tumor in the women who are in a premenopausal state. That means less than 35 years of age. And please note, it will appear as a well-defined mobile mass. A irregular mobile mass could be the fibrocystic changes, but a well-defined mobile mass will be the fibroadenoma always. Okay.
Yes.
Even in case of cancers, you will see that this mass is not well-defined. It is an irregular mass. The mass could be mobile, could be non-mobile. So, this well-defined feature, a highly characteristic feature of the fibroadenoma, as well as this mobile mass. So, a solitary lesion, a solitary mobile mass always signifies a fibroadenoma. Okay. And whenever you perform the biopsy of the patient, what you will find is a fibrous tissue and glands in it. You will have a fibrosis, and that's why the name fibroma. Okay, you will also have the glands in it. Okay, size will be increased whenever you have an increased exposure to the estrogen. That means with the pregnancy, with each cycle, you will have a cyclic pain in the breast also. So a cyclic pain will be there in the in this fibroadenoma as well as in the fibrocystic changes. But the irregular mass and the regular well-defined mass will help to differentiate between these two causes, right?
Right.
Again, if the multiple masses are present, this could be the fibrocystic changes. If a solitary lesion is present, this could be the fibroadenoma. So after the menstruation, this tumor will regress completely, just as the leiomyoma. So no need to treat the condition. Okay. And the risk of the cancer, it generally does not increases. Okay. And when you perform the biopsy of the patient, what you will find at some locations, you will find a normal ducts. At some location, you will find the slits. Because what is happening, you will have the increase in the amount of stromal tissue. Fibrosis of the stromal tissue is happening. Now see, if this is a breast, for example, normal breast, right? You perform the histology of the breast, you will find the glands here, right? These are all the glands, the lobules. And in between the lobules, you have the stroma, right? All of this is a stroma, yes? In case of fibroadenoma, this stroma is expanding. And when the stroma is expanding, it will cause the compression of these ducts and the lobules, right?
Yes.
And when the compression of these ducts and lobules happen, what you will see at some location where the proliferation of the ducts are present, you'll be having a normal ducts. Okay. But at some location where the stroma is proliferating too much, you'll be having a slit-like appearance of these ducts. These ducts will become only a slit-like thing, right?
Yes.
So you will have two type of patterns. One is the pericanalicular and second is the intracanalicular. In the pericanalicular, you will find these ducts. In the intracanalicular, you will find the slits only. Okay. So that's about the histology. As you can see, yeah, this kind of a thing will be seen, right? This kind of a slits will be seen. Okay. Although it is not a histology feature of this tumor, but that's again, these exactly kind of slits you will see. Okay. Other than that, ducts will also be present. On the ultrasound, what you will find is a mobile mass, right? As you can see, this is a well-defined mobile mass, right?
Okay.
So this kind of a mass, a well-defined mobile mass will be seen on the histology. Okay, and on the histology, you will find the ducts and the slits. Any doubt, please ask.
So intracanalicular is inside the duct?
Intercanalicular is just either compressing the ducts, not inside the ducts, but compressing the ducts due to an increase in the stromal tissue, as like that. Okay, this tissue is increasing, and as a result, all the ducts are compressed, right?
Okay, so then what does pericanicular mean?
Yeah.
So then what does pericanicular mean?
And this pericanalicular pattern is just the glands are totally normal. The stromal tissue is not increased so much that it could compress the glands. The glands are totally normal. The ducts are totally normal. Okay. The stromal tissue just, it just going, it is going outside the tissues, right? Outside these ducts. But in case of my intracanalicular, it just growing so much, it is compressing the ducts.
Okay.
That's only the things you will know. Okay. So these two type of patterns will be seen. It is appear like this, it is appear like this. These tumors are actually inside these ducts, right? It seems like that. That's why the intracanalicular, but it is not really that this case is not like that. It's just the stromal tissue is increasing, which is compressing these ducts in the actually part. Okay.
Okay. And one doesn't lead to the other, right? They're just two different presentations.
Yeah,
of the same.
exactly. Exactly.
Okay, thank you.
Second, you have is the intraductal papilloma. Okay, where you have the tumor which is arising within the lactiferous ducts. Okay, it typically seen beneath the areola. Okay, and again, just let me draw this for you. If this is my duct, okay, and inside this duct, if I'm having a papilloma, that means a finger-like projection, right?
Yeah.
Interductal papilloma, that means inside the duct, I'm having a papilloma, that means a finger-like projection of the cancer, right?
Right.
So in this endoductal papilloma, if I'm having this projection, can this projection bleed?
Yeah.
So because this projection bleeds, what you will have is a bloody discharge from the nipple. So whenever you encounter a patient having a bloody discharge from the nipple, you will always think about the intraductal papilloma, okay?
Yeah.
Now, just like any other papilloma, when you perform the biopsy, what you will find is at the center, at the core, you will be having a fibrovascular area, stalk, that is surrounded by all these cells, right? These tumor cells.
Right.
Yes. And that is a normal histology of any kind of a papilloma. Okay. A fibrovascular core, which is surrounded by the epithelial cell as well as the myoepithelial cell. You have two cells in the ducts. One are the epithelial cells and one are the myoepithelial cells. The function of the epithelial cells is to line the ducts, and the function of myoepithelial cells is to cause the contraction in response to the oxytocin that causes the release of the milk, right?
Right.
So again, it has a normal histology, both the epithelial ducts as well as the both the epithelial layers as well as the myoepithelial layer is present. Okay, and that all layers is present around the fibrovascular stalk. Okay, that is what you will see on the histology of the patient with the intraductal papilloma. A bloody discharge will be present. That is a highly characteristic feature. Then you have the phyllodes tumor. As the name suggests, this tumor is leaf-like. Okay, as you can see, this tumor is having a leaf-like thing, right?
Right.
Appreciating that. So that's exactly a histology. Based on the histology, they have given this name, the phyllodes tumor. It is a very large mass. Okay, it has size more than that of fibroadenoma. Okay, and this tumor has a leaf-like projection also. Okay, And this tumor is again most common in the fifth decade. That means in the 50s, 51, 52 to 60 years of age. This tumor is common, while the fibroid adenoma is common in the 35 only, right?
Yeah.
So that's about all these benign tumors. Any doubt?
No, that's okay.
Okay, so let's take a short break and then discuss the gynecomastia, okay?
Okay.
Okay, so gynecomastia is basically the breast enlargement in the males. Okay, and that happens whenever the males have a high activity of estrogen than the androgens. I told you about two limits, about the androgens and the estrogen. Whenever the estrogens are more than what it should be, what they should be, they will all the males will always have the gynecomastia, right? So basically, please note that it is physiological in the pubertal area. Okay, whenever the males hits the puberty, they will have a lots of androgen in them. Okay, and all of that androgen, most of it, will be converted into the estrogen. So at the time of puberty, having a gynecomastia is totally normal. Okay, but after that, if this male is involved in some kind of a athletic activity, or maybe a weightlifting activity, or maybe anything like that, then a high chances are there that this male is taking the this androgen abuse is there, right? And that again can lead to gynecomastia. So whenever you encounter a male who is totally normal, okay, no athletic activity, no weightlifting, nothing, a totally normal male who just hits the puberty and now he's having a gynecomastia, think about the physiologic the gynecomastia. If the male is involved in some kind of a activity, athlete, weightlifting, or anything, that means a high chances are there that this male could be abusing these steroids, and that is causing the gynecomastia. Is that okay?
Yeah.
So Stephen will give you this such kind of a patients, and based on the history of the patient, based on the age of the patient, you have to determine whether it is a case of the androgen abuse or whether it is a normal or a physiologic the gynecomastia. Now some other drugs or other conditions which can cause a gynecomastia. Okay, this includes the cirrhosis, because whenever you have a cirrhosis, the liver cannot metabolize the estrogen, right?
Right.
If the liver cannot metabolize the estrogen, patient can end up having a gynecomastia. Hypogonadism, like the Klinefelter syndrome, can do that. And a testicular tumor, which is releasing the high amount of androgens and then a high amount of estrogen, can lead to the gynecomastia. Okay, certain drugs which are anti-androgenic, they can lead to the gynecomastia, and let's discuss these drugs. First, again, you have the estrogen, and that again causes the ductal epithelial hyperplasia. And due to the hyperplasia of the ducts, patient can have a gynecomastia. Anti-androgenic drugs, okay, that basically inhibits the receptors of the testosterone. They can lead to the conversion of testosterone into the androgens, into the estrogen, and that can lead to gynecomastia. 5-alpha hetase inhibitor, which is basically a finasteride, that inhibits the conversion of testosterone into the dihydrotestosterone. That means, whatever the available testosterone is there, it will all be converted into the estrogen now, and that again can lead to the gynecomastia. Spironolactone, which basically decreases the synthesis of the testosterone as well as blocks the receptors of the testosterone, both activities. It can lead to the gynecomastia. The ketoconazole, which is an antifungal drug, and one kind of antifungal drug it is.
The inhibitor?
What inhibitor?
Cell membrane inhibitor.
17-alpha demethylase, remember?
Sorry.
17-alpha demethylase.
Okay.
Okay, the ketoconazole. So basically, they also this ketoconazole, it also inhibits the secretion or the synthesis of the steroid hormones. That means it can lead to the gynecomastia again. Cimetidine, which is what kind of a drug it is?
Antihistamine.
Anti?
Antihistamine. Histamine. Antihistamine.
Yeah, antihistamine drug. Right. Cimetidine, which is an antihistamine drug, it can again block the receptors for testosterone. It can lead to the gynecomastia. Now, anabolic steroids, if the patient is abusing these steroids, taking the these exogenous steroids, patient can again end up having a gynecomastia. So whenever you encounter a male patient who is involved in some kind of athletic activity, that means high chances are there that this patient is having a gynecomastia because of the androgenic steroid abuse. Okay, while these other drugs can again lead to the gynecomastia. And if it is a normal male, Okay, a male just hits a puberty, like 15, 16, 17 years old without any activity of athletes. High chances are there that this could be a physiologic gynecomastia. Okay.
Yeah.
So that's about the gynecomastia. Any doubt?
No, it's okay.
Okay. Now comes the breast cancer. Okay. And almost every time the breast cancer always arises in the females having an age of more than 50 years. Okay. So always a postmenopausal female with the breast cancer. Okay. The screening test you perform to detect the breast cancer is the mammogram. Okay. And in the mammography, you can see that this kind of a calcification is visible in the breast. Okay. And whenever you see this kind of palpable mass or a mammography showing this kind of a calcified nodule, a high chances are there that this patient is having a breast cancer. But in a premenopausal state, okay, whenever you encounter a patient having this kind of a mammography, it will suggest that the patient could be having a fat necrosis, remember?
Yes.
While if the patient is having a family history of breast cancer or any associated cancers with the breast, okay, then this means that the patient, in a premenopausal patient can also have a breast cancer in that case, right?
Right.
For example, the BRCA2 and BRCA2 mutations, the patient will have an early age of the breast cancer, like in the 30s or 40s only the patient will get the breast cancer. So again, if you got a positive mammogram, that means a high chances that the patient could be having a breast cancer, not a fat necrosis. Okay.
Yes.
Now, the breast cancer will always appear as a palpable mass, and the most often location of this palpable mass is the outer upper quadrant of the breast. See, if this is a breast, you have 4 quadrants, okay, and most of the times this is a lateral side, this is a medial side, okay, this is towards the head or upper side, this is towards the toe or lower side, okay. Most of the times the cancer will arise in this quadrant, which is the outer and upper quadrant, right?
Yes.
Okay.
Yes.
So whenever you encounter this patient, they will always tell that they are having this hard lump on the outer upper quadrant of the breast, and that is highly suggestive of a breast cancer. Okay. Now, after that, when the cancer occurs, you will get the necrosis again, right? Hemorrhagia and this necrosis that can lead to the healing with the scarring, right?
Yes.
And when these malignant cells infiltrate the corpus ligament, and these corpus ligament are present in the stroma of the breast. Remember the stromal tissue?
Yeah.
That stromal tissue contains this corpus ligament, and when the malignant cells infiltrate this area, when the death of the cells occur, okay, when the healing occur, fibrosis occur, that can lead to the contraction of these ligaments. Okay, shortening of these ligaments occur, and as a result, at the site of the cancer, patient will get a skin dimpling. Okay, nipple retraction or skin dimpling always present because of this involvement of the corpus ligament. Is that okay?
Yeah.
Yes.
These corpus ligaments are also known as the suspensory ligaments. So step 1 will ask you, whenever you have a breast cancer, you have a skin dimpling. Why this skin dimpling is occurring? It is because of the infiltration of these metastatic cells into the corpus ligament or the suspensory ligament that is causing the retraction or shortening of these ligaments. Is that okay?
Yeah.
So 2 features, one is the mass and second is the skin dimpling. These are very highly characteristic features of the breast cancer. Okay. Most of the times these cancer arises from the TDLU. Okay. Sometimes they could be associated with the mutations such as the ERB2 mutation. Remember the ERB1 or HER1? Lung cancer. Okay.
Yeah. EGFR.
Yeah. Okay. So ERB1 for the lung cancer, ERB2 for the breast cancer. Okay. So ERB2 would be there, which is basically a estrogen growth factor. Okay. Second thing, the patient can also have, the mutations like the BRCA1 mutation, BRCA2 mutations, right? So now the patient can have a mutations in the estrogen receptors. Patient can have a mutation in the progesterone receptor. Depending upon that, the patient could be either ER positive, PR positive, HER2 positive. Patient could be negative for all of these threes. Now, if a patient is having a estrogen receptor positive breast cancer, that means if I block the receptors of the estrogen, I can have a recovery from this cancer.
Yeah.
Similarly, if I have a cancer which is prostrate receptor positive, that means this tumor is responding to the progesterone. So if I block these receptors, can I have a resolution of symptoms?
Yes.
Similarly, if the tumor is HER2 new positive, if I block this receptor via drug which is
Letrozole.
Trastuzumab?
Antibody, yeah, trastuzumab, right, which is an antibody against this receptor. So if I have this receptor positive and if I give the patient this antibody trastuzumab, can I have the recovery from this cancer again?
Yes.
So having a breast cancer with these positive is kind of a good thing, right?
Yes.
Now, if you have a tumor which is HER2 new positive, okay, that this means this tumor, these tumors are very highly aggressive type, and they will cause an early metastasis, and as a result, these tumors have a very low prognosis or a very poor prognosis. Is that okay?
Yes.
Because these tumors are highly aggressive, that's why these tumors are very poorly progressive. These tumors have very poor prognosis. Okay, while the tumors who are ER positive or PR positive, they have a very good prognosis, because if you give the patient the drugs which blocks these receptors, this will cause a recovery from this cancer, right?
Yes.
Now,
Okay.
a cancer which is triple negative, if I can give any drug, that won't help this cancer, right?
Right.
And as a result, having a triple negative is basically a most this aggressive type. Okay, so of ER positive, PR positive, good prognosis. HER2 new positive, kind of a very low prognosis. Okay, but having a triple negative is the very least prognosis or very poorest prognosis. Okay.
Yeah.
Is that because that will make it more responsive to choices of
Drugs.
therapy, or
Yeah, exactly. Because if the tumor is ER positive or PR positive, then it can respond to the therapy, right?
yes?
But if the tumor
Okay.
is not positive for any of these receptors, then it won't respond to the therapy. The ultimate treatment
Yes.
is the surgery. But if the metastasis again occur, then surgery won't help again,
Okay. Yes.
right?
Yes.
So
Thank
that's
you.
why you will always check for the ER positive, PR positive, and HER2 new receptors positive thing. If you got a positive, it means it is a good thing. If you got a negative, it is a bad thing for the tumor. Okay. So most
Okay.
of the times the tumor originate, if it is happening sporadically, always happens in the postmenopausal females. But sometimes the premenopausal females can also have the breast cancer, and generally it is because of a mutations. It is because of a familial conditions. Okay, the patient can be having a BRCA1 mutation or a BRCA2 mutations. If the patient is nulliparous, that will increase the risk of having a breast cancer. Okay, if the patient is having a history of obesity, then because of high adipose tissue count or the number, the patient will be having an increased conversion of androstenediones to the estrogen, right?
Yeah.
That can again expose the patient to a high amount of estrogen that can lead to the breast cancer again. So a postmenopausal obese female will be at an increased risk of having a breast cancer, right?
Right.
Absence of breastfeeding will increase the risk of again cancer. Okay, so nulliparity, absence of breastfeeding, okay, and the alcohol intake can also increase the cancer. In the males, having a BRCA2 mutation will increase the risk of breast cancer. So the male patients can also have a breast cancer, and that happens whenever they have a familial BRCA2 mutation or if they're having a Klinefelter syndrome. Okay.
Yes.
Yes.
Now, the lymph nodes which are draining the lymph from the breast, these are the axillary lymph nodes. So whenever the cancer occurs in the breast, it will first drain to the lymphatics and it will go into the axillary lymph nodes, right?
Yeah.
So whenever you encounter a patient with a breast cancer, you will always check for the axillary lymph nodes. They will cause a dissection there. And after dissecting the axillary lymph nodes, you will check whether the tumor cells are present there or not. If the tumor cells are present there, that means the metastasis has already been occurred. And as a result, this patient will be having a very poor prognosis, right?
Yeah.
So apart from the mammography, if you see that mammography is positive, you will always check for the, remember, for the TNM staging, the T stands for
Tumor size.
tumor size and
Lymph node involvement.
And M, metastasis to other tissues, right? So again,
Yes.
N and M has a more prognostic values, right? So for the N and M, you will check for the lymph nodes of the patient. If the lymph nodes are positive for the tumor cells, that means the N is positive and is very high, and as a result, patient is having a very high stage number. That means a very poor prognosis, right?
Yes.
And does anyone remember the complications you can have while doing the axial lymph node dissection?
Lymphedema.
Okay, lymphedema can happen. Another from
Winging,
musculoskeletal, any
yes,
nerve
winging
damage?
the scapula, winging scapula.
Yeah, winging of the scapula by
Injury, long thoracic nerve injury.
yeah,
Long thoracic nerve injury.
yeah, long thoracic nerve of Bell, yes, which is giving a branch to the what muscle?
Infraspinatus.
Serratus anterior. Yeah, serratus anterior. Okay.
Yes.
So you can have a damage of this nerve that can cause the winging of the scapula because of a loss of innervation to the serratus anterior. Okay. So that is
Yes.
basically a complication of the axillary lymph node dissection. Again, lymphedema can happen, and in the long term, that lymphedema can lead to what type of a cancer?
Lymphangiosarcoma.
Angiosarcoma, yes. Okay. So again, because of this dissection, patient got a lymphedema, and a chronic lymphedema has caused basically the angiosarcoma in the patient. Okay. Any doubts so far?
No.
So that's about the generalized features of all the breast cancer. Postmenopausal female, more than 50 years of age, sporadically, okay, having a history of obesity, alcohol intake, having a history of nulliparity, or having no history of breastfeeding will increase the risk of developing the cancer. Familial cases will always present you with a premenopausal breast cancer. The patient could be having a BRCA1, BRCA2 mutations. Okay, these cancers will always arise from the upper outer quadrant. The patient will feel a lump in the upper outer quadrant. You perform the mammography, you will find the calcifications positive. You will have a retraction of the nipples or the skin at the side of the cancer. And that is again a very highly characteristic feature of the cancer because of Cooper's ligament involvement, right? Having a triple negative means a very poor prognosis. Having a ER positive, PR positive implies a good prognosis. Having a HER2 positive again makes this cancer very much aggressive. So again, a very poor prognosis. Okay. Now let's discuss what different type of cancers you have. You have two type of cancers, the non-invasive ones and the invasive ones. The non-invasive ones are the kind of benign type, okay, and the invasive ones are kind of highly malignant or aggressive type, okay.
Yeah.
Okay, so first, the cancers can be arise from the lobules because most of the times this cancer arises from the TDLU, right? The terminal duct lobular unit that contains the lobules and the ducts, right?
Yes.
So these tumors can arise from the lobules, or these tumors can arise from the ducts. When the tumors arise from the ducts, you call it a ductal carcinoma, and when the tumors arise from the lobules, you call it a lobular carcinoma. So now, because this condition is non-invasive, the tumors are not invading the basement membrane, and whenever the tumor does not invade the basement membrane, remains through tissue only, you will call it a carcinoma in situ always, right?
Yes.
Like cervical carcinoma in situ, remember?
Yeah.
Yes.
So in all these non-invasive carcinomas, you will call it a carcinoma in situ. So a ductal carcinoma in situ, a lobular carcinoma in situ. Okay. So the ductal carcinoma in situ will arise in the ducts. It will cause the filling of the ductal lumen. Okay. Very important thing. And you will see again the microcalcifications on the mammography, and these microcalcifications occur because of a death of the cells in the center. You have the duct. You have a duct here. Okay, and this duct is fully filled with the cancerous cells. In the center, because the hypoxic environment is there, you will get a necrosis of the cells, right? And that will lead to the calcifications, again, dystrophic calcifications. Yes?
Yeah.
And these dystrophic calcifications can be screened with the help of mammography. They will be detected with the help of mammography. That's exactly what you will see, right?
Yes.
So let me show this. Yeah, these are basically the tumor cells filling up the lumen. These are the blood vessels, okay? And these are the tumor cells which are filling the your ducts, okay? And these are the stromal tissue. All this collagen is present here. The blood vessels are present here. Corpus ligament are present here, right?
Yeah.
Okay.
And zoom it. Just give me a second. Yeah, as you can see, this is a blood vessel which is present in a stroma, and these are the ducts. Okay, these are the ducts, and this duct is fully filled with the cancerous cells because normally the ducts are empty, right?
Yeah.
But these ducts are not empty, they're filled with the cancerous cells. So this is the stromal tissue which is containing the blood vessels, corpus ligament, collagen, and other things. Okay, that's what the histology will be of the breast cancer. Okay.
Okay.
Now you have a variant of this cancer which is known as the chlamydiocarcinoma. It is a subtype of ductal carcinoma in situ. Okay, in this case again you will be having a central necrosis which is causing the dystrophic calcification. Basically, it is a highly aggressive tumor. Okay, a variant of this ductal carcinoma in situ. Nothing much more important. Okay, and please note all of these non-invasive cancers, they never produce a mass. So basically, at the time when you diagnose these conditions, when the patient diagnosed this condition, it would become very late, right? When the metastasis occurs, right?
Right.
So that's why the screening for the breast cancer, that means by the mammography, is the only way by which you can detect these cancer, because you won't have any mass, you won't have any lump. It's just the calcifications are present, which will be detected by the mammography. So that's why the mammography is very important for such cancers. Okay, because they do not produce any kind of a mass. Okay.
Yeah.
Now, second you have is the Page's disease. Okay. Now, when this ductal carcinoma in situ cells, when they invade the ducts, and basically they goes and they involve the lactiferous ducts, and finally the skin of the breast, when involved by these cancerous cells, it will become a Page's disease of the breast. Okay, you will get the eczema, you will get the patches, you will get the hemorrhage, you will get the necrosis, you will get the pruritic condition over the nipples. As you can see, this kind of a thing will be seen on the breast. These are all the cancerous cells invasion of the skin. Okay, when the ductal carcinoma cells, let me draw this. If yeah, if this is a duct, okay, you have the lactiferous sinus here, and finally you have the nipple here, right? You have all this skin area here. Okay, you have a cancer which is originating at this duct, blocking the duct. When these cells invade the lactiferous duct, it will cause a filling of the duct here. And finally, these cells will reach to the skin, right? They will involve the skin and causing the invasion in the skin, right? That causes the Page's disease. Patient will be having ulcerations. Patient will be having, all this hemorrhage on the nipples, on the areolas, on the nipples of the breast. Patient will be having a pruritus. Eczema will be there, right? A necrotic rash is present over the breast. And that's how you know that the patient is having a Page's disease of bone. Okay.
Yes.
Now you also know about the melanoma, right? This melanoma can have a color variations. It could be reddish to brownish to blackish, right?
Right.
And as you can see, this Page's disease again is reddish, brownish, blackish, right?
Yeah.
Yeah. And they're also having irregular borders. See? Right?
Yes.
So this condition can even mimic the melanoma. So how will you differentiate between the two? In both the melanoma and in this condition, you'll be having a pruritus, eczema will be present, multiple color variations will be there, irregular borders will be there. So these two things could be very much similar to each other. So how will you differentiate?
Mammography.
Okay, mammography will help. Okay, one thing. And any other lab thing you will do? Any tumor marker?
S100.
S100, yes. You will perform the S100. If you have a S100 positive, that means it is a melanoma. If you have a S100 negative, that means it is a breast cancer. Okay.
Yeah.
Yeah.
Okay. So when the DCIS, when it is spread to the nipples, when it is spread to the skin, you will call it a Page's disease. Second, you have other type of cancer. You have is the lobular carcinoma in situ. In these cancers, they arise from the lobules. And the highly characteristic feature of this cancer is that it loses the E-cadherin expression. And remember about this E-cadherin?
Yeah. Krukenberg tumors.
Okay. And any other normal function of this E-cadherin?
Without E-coherent, you don't spread out your cells properly and they grow on top of each other.
I do not have the spread of this of my cells, right? You're saying without this expression.
No. With E-coherent, you lose the organization. So cells will grow on top of each other.
With E-coherent or without E-coherent?
Without E-coherent.
Without E-coherent, I cannot have the proper organization. I will have the cells on top of each other.
Yes.
That you're saying. So you're saying that cells are attached to each other, right?
Yes.
No, that exactly opposite happens. See, the function of this E-coherent is to hold the cells together. Okay.
Okay.
So when this E-coherent is lost, you will have, the movement of cells throughout the tissue. Okay. Individual cells could be seen. As you can see, these are the individual cells which are not attached to each other. Okay. See, all these cells are very much differentiated from each other, right? So these cells, because they loses the property of attachment to other cells, they will spread throughout the tissue. Okay.
Okay. I thought that that loss of E-coherent was the reason why they could metastasize past the basement membrane.
Yeah,
But
exactly. See, in order to metastasize, you need to detach from the surrounding cells first, right?
Okay.
Then after detachment, you will attach to the basement membrane, and that could be done by hemidesmosomes, right? Integrins, and what are the other proteins you need? One is the integrin.
Coherence, like the tight junctions, cadexins, that stuff.
Yeah, exactly. The integrins and one more thing. The laminin. Remember the laminin, fibronectin, integrins, right? In order to attach to the basement membrane via hemidesmosomes, you require the integrins, laminin, and fibronectin, right?
Okay.
So after detaching from the surrounding cells, these cells will attach to the basement membrane via these proteins, and then they invade the basement membrane. Okay.
Okay.
So the E-coherent found in the adherent junctions. Remember the adherent junctions,
Yes.
which connects the actin of two cells together, right? And then you have the desmosome connecting all these intermediate filaments together, right?
Yes.
So without the E-coherent, you will lose the adherent junction, and as a result, the two cells cannot be adhered to each other, right? They will spread out now throughout the tissue. They can move anywhere inside the tissue, right?
Okay.
So now because these cells are moving inside the tissue, they won't form any mass. Okay.
All right.
And because they are not forming any mass, no calcification will be seen, right? Because they can move freely into the tissue. They can find oxygen anywhere. They can find nutrition anywhere, right? No hypoxic environment will be generated, because for the hypoxic environment, you need a mass of the cancer, right?
Okay.
But now a lot of space is there. Okay, lot of these nutrients are available. Okay, everywhere. So no calcification will be seen. No necrosis will be there. No mass will be there, right?
Okay.
So that kind of a thing will be seen in the lobular carcinoma in situ. So the special feature of this cancer is that they will lose the E-coherent, and as a result, they won't form any mass. They are not forming any mass, so they can go anywhere inside the tissue. And now because they can go anywhere, they can even involve the contralateral breast also, right?
Yeah.
So most of the times, it could be a bilateral cancer also. Okay.
Okay.
So these patients will be having an increased risk of cancer in either of the breast, versus in case of my DCIS, it will always involve the same breast, same quadrant, right? Upper lateral quadrant.
Yeah.
Okay. But in case of my lobular carcinoma in situ, both the breast could be involved. Bilateral cancer it could become. Okay. So please note, it start with the loss of E-coherent because of a mutation. So we'll lose the adherent junctions, and as a result, the cell will not attach to each other. They will and they will move freely inside the tissue. They will involve the other breast also. No mass formation will be occur. No calcification will be occur. So it will be an incidental finding on the biopsy always. Okay. And that's why it is a very kind of, very dangerous kind of a cancer, right? Because you cannot detect it.
Okay. Yeah, that makes sense.
Okay, that's what you see in the lobular carcinoma in situ. Now you have the invasive cancer. In all of the invasive cancers, they will be invading your basement membrane, right? And by invading the basement membrane, they can metastasize early. Okay, so first you have the invasive ductal carcinoma. Okay, and in that case, we have a fibrous rock hard mass. Okay, and this rock hard mass will be having a sharp margins. Okay, now the sharp margins can also be seen in the fibroadenoma. Remember, a hard
Yes.
mass which is highly kind of demarcated sharp margins present, right? So how will you differentiate between an invasive ductal carcinoma and the fibroadenoma based on the examination?
Fibroadenoma is very mobile.
Exactly. The fibroadenoma is mobile, but the invasive ductal carcinoma is not mobile. Okay, so having a sharply demarcated mass which is immobile, you will think about the invasive ductal carcinoma. Having a sharply demarcated mass which is mobile, you will think about the fibroadenoma. Again, the age of the patient is also important. Postmenopausally, you will find the invasive ductal carcinoma. Premenopausally, you find the fibroadenoma, right?
Right.
So that's about the invasive ductal carcinoma. Okay. Second, you have the invasive lobular carcinoma. Again, you will have a loss of E. cadarin, right? You will have a row of the cells which are found in a single file appearance. As you can see, this is a single file appearance. Okay. As you can see, they form the lines, right? They form all these lines. Okay. And that's because they're losing the E. cadarin. So they cannot be attached with each other, right? They're not adherent with each other. They will lose the adherence property. So they can move freely within the tissue, right? And they form this single file-like pattern. Okay.
Yeah.
So these line-like structures you will see on the biopsy of the patient whenever you see a invasive ductal carcinoma in situ. No duct formation, nothing will see, just these file-like patterns will be seen. These lesions are often bilateral, okay, and multiple lesions could be found on the same location. Okay. Then you have the medullary carcinoma. Okay, and these carcinoma can, they have the lymphocytes as well as the plasma cells. So whenever you have this kind of a medullary carcinoma, it will make you think that this could be a case of inflammatory conditions, right?
Right.
And this tumor can also mimic the fibroadenoma because it is a well-circumscribed tumor. So again, the age of the patient will help you differentiate between these two cancers. So if you have a breast mass, okay, again, a sharply demarcated breast mass, and on the biopsy of that mass, if you're seeing the lymphocytes and the platelets and this plasma cells, that means it is a medullary carcinoma, okay?
Yeah.
So that's about the medullary carcinoma. Then you have the inflammatory invasive carcinoma. Actually, it is not an inflammation, but actually, it mimics the inflammation type thing. It can mimic the mastitis also, mastitis, okay? So what happens is, when the cancer cells metastasize, they will cause a blockage in the lymphatic ducts, okay? And when the lymphatic ducts got blockage, what you will have is a lymphedema in the breast.
Yes.
See, you're having a cancer cells. These cancer cells are invading my basement membrane, ending my lymphatics. When they metastasize via lymphatics, they can even block the ducts of the lymphs, right?
Yeah.
So
So if the lymphatic ducts are blocked, then you cannot have the lymph drainage now.
okay.
If the lymph drainage is not there, you will get a lymphedema of the breast, right?
Yes.
The patient will get a warm and swollen breast, as you can see. Okay, red skin will be there. This condition is very painful. Patient will get a breast pain. Okay, but let's see. Now let's discuss that. So you encounter a patient having a very pain in the breast. The breast become very diffusely enlarged. Okay, red will be there, warmth will be there, swelling will be there. So you can think about a mastitis, right? It could be inflammatory condition also.
Yeah.
Right? Because in case of inflammation, you have this reddishness of the breast, edema of the breast, swelling will be present, pain will be present, right?
Right.
So how will you differentiate between a mastitis and this this cancer, inflammatory cancer? How will you differentiate between the two?
Recent history of breastfeeding and acute mastitis.
Okay, a recent history of breastfeeding could be present. Apart from that, on the examination, what you will see? What is a characteristic feature of the breast cancer?
A mass is felt.
Okay, mass. Other than the mass?
Nipple retraction. Skin
Exactly
depression?
that. Yeah, skin retractions, dimpling of the skin, right?
Yeah.
So along with these features, along with having a redness, swelling, pain, okay, in the breast, apart from that, if the patient is also having a dimpling of the skin, that will tell you that the patient is having a cancer, not an inflammatory condition, okay?
Yes.
And because of this dimpling and swelling and all this redness of this breast, it will appear as a PDO orange. If you ever see a orange, it has dimples on it, right?
Yep.
So because of lots of dimple on this breast, it will appear as a PD orange, okay? So that can be often mistaken for the mastitis or maybe the Paget's disease. So you will see the dimpling of the skin, and that's how you know that this is a basically this inflammatory invasive carcinoma, okay? And because the metastasis has already been occurred, this case is always has a very poor prognosis, okay?
Yes.
And what is the most common lymph node for the metastasis in the case of breast?
Axillary.
Axillary lymph node. So whenever you examine the patient, you check for the axillary lymph node, you will always found that the patient is having a metastasis in the axillary lymph node. So apart from this swelling, patient will also have a presence of metastasis in the lymph nodes, right? You will find a lymph node positive. Okay, so whenever you have a lymph node metastasis to the axillary lymph nodes, the malignant cells can block the lymph nodes, and as a result, patient will get a PDO orange of the breast. The patient will have a thick dimpling skin like an orange peel. They will be having a swelling of the breast, redness of the breast, pain in the breast, right? So that is the inflammatory invasive carcinoma. Any doubt?
No, thank you.
Okay. So that's about the breast cancer. And please note, unlike my brand conditions like the fibroadenoma, which has both the epithelial as well as the myoepithelial cells, right? In case of my invasive and non-invasive carcinoma, they do not have any myoepithelial cells, just the epithelial, okay?
Okay.
So on the histology, if the step one asks you what kind of a cells are present, myoepithelial, epithelial, or both, okay, you will always choose the epithelial only. No myoepithelial cells are present, unlike in case of my fibroadenoma. So any doubt, please ask.
No, thank you.
Okay, so that's about the breast cancer. Now you have the pathologies. First we have is the Peyronie's disease. Okay, and it happens because of an abnormal curvature of the penis. As you can see, the curvature of the penis become very abnormal. It happens because of a fibrosis in the tunica albuginea. Remember the tunica albuginea?
Yeah.
Which is the innermost layer of the testis, and it also covers the slenders, right?
Right.
So whenever the fibrosis happen, it will cause a contraction on one side of the slender, and as a result, you will have this abnormal curvature of the penis, right? And this condition is mostly associated with the erectile dysfunction. Of course, whenever you got this abnormal curvature, patient can have anxiety also, right? And of course, the treatment will be the surgical repair. Okay, and you can also give the patient collagenase because, of course, in the fibrosis, what protein you will have?
Collagen.
Collagen. So if you dissolve the collagen, you can again get a treatment from this condition, right?
Yeah.
Okay.
Now, please note that this is not a fractured condition. In case of a fracture, you will have a fracture within the slenders, right? This is a different thing. Fracture condition will become very painful, but this condition is not painful, okay? And bleeding again won't be present in case of this condition, while bleeding will be present in case of fracture, okay?
Yes.
Should I repeat it again?
No, it's okay.
Okay. So this is the Peyronie's disease, and similar thing could be seen in the fracture also, peroneal fracture, right? But the two things will help you differentiate. One is the bleeding, and second is the pain. If the pain and bleeding is there, that means this abnormal curvature is due to the fracture. But if no pain is there, no bleeding is there, just somehow you got this kind of a curvature, we'll call it a Peyronie's disease. Then you have the ischemic priapism that happens whenever the erection is lasting for more than 4 hours. And as a result, the organ start now becoming the ischemic. Okay. This generally happens with the sickle cell anemia, because whenever you have a sickle cell anemia, you can have a blockage of the ducts, right? Veins specifically. If the veins got blocked, you won't have a drainage of the blood. As a result, the blood will be filled in the cylinders, right?
Right.
And whenever the blood is filled in the cylinders, you will have an erection, right? And now this condition become very much painful. So whenever you have a painful erection for more than 4 hours, you will call it a ischemic priapism. Okay. And I told you in psychiatry part, if you give a patient trazodone to a sickle cell anemic patient, they can have a ischemic priapism, right? Remember?
Yeah.
So this ischemic priapism is a side effect of the trazodone that is especially seen in the sickle cell anemic patient. If you give the patient sildenafil again, because of this prolonged this erection, patient can again have a ischemic priapism because of that. Okay. So the treatment will be to give the patient vasoconstrictive agents that will cause a drainage of the blood, right?
Okay.
And that includes giving the patient phenylephrine, because this thing is happening whenever you have a blood is filling in the cylinders, right? So you have the erection that will causing a very severe pain to the patient. To treat this condition, you will drain the blood from the cylinders, or you will decrease the blood supply to the cylinders, right?
Right.
So the treatment the treatment will include giving the patient vasoconstrictive agents like the phenylephrine. Remember the function of this phenylephrine?
Alpha-1 agonist.
Yeah, a pure alpha-1 agonist. Okay. So that was about the ischemic priapism. Any doubt?
No, thank you.
Then you have this squamous cell carcinoma of the penis. Okay, and just like any other squamous cell carcinoma of my reproductive tract, this squamous cell carcinoma is also caused by the human papilloma virus. And I told you, whenever you have a squamous cell carcinoma, what is a gross finding you will see?
Hemorrhage and necrosis.
Hemorrhage, necrosis, and ulcers. So whenever you see hemorrhage, necrosis, and ulcers over the penis, okay, and they can also have the leukoplakia. Remember the leukoplakia of the vulva in this squamous cell carcinoma I told you, right?
Yeah.
So similarly, in case of my penile carcinoma, patient will also have a leukoplakia. So apart from the leukoplakia or this whitish spots, patient also have this ulcers, necrosis area on the penis, and you will call it a squamous cell carcinoma. Okay. Apart from this white plaque, patients can also have a reddish plaques. Okay. So both the white plaque as well as red plaques can be seen. Okay. So that's about this squamous cell carcinoma. So once the patient is having these white plaques or the red plaques, then they start having these kind of ulcers or the hemorrhage or necrosis. They will call it a squamous cell carcinoma. Most of the cases are seen in the human papilloma virus. Any doubt?
No, thank you.
Then you have the cryptorchidism, which is basically the failure of descendant of the testis. When the testis does not descend properly from the abdomen into the scrotal sac, you will call it a cryptorchidism. Now, why does these testis need to reach the scrotal sac?
For spermatogenesis, the temperature of low value.
Yeah, because what happens is the scrotal sac provides a temperature which is lower than the body temperature. Okay, and this low body temperature is required for the proper functioning of the Sertoli cells. I told you that Sertoli cells are very temperature sensitive. Remember?
Yeah.
So if the descent of the testis does not occur, your testis will expose to a high temperature, which is the body temperature. And as a result, the Sertoli cells will not function. What you will get is a failure of functions of the Sertoli cells. You will get a loss of spermatogenesis, right?
Right.
That will cause infertility to the patient. Now, I told you that the Leydig cells are not temperature sensitive, right?
Right.
So you will have a normal testosterone production, but no production of the inhibin or no production of the estrogen will be seen, right?
Right.
So what kind of a hormonal thing is present in the patient?
Normal testosterone.
Testosterone will be normal, yes. What about the FSH and inhibin?
Low
Uh,
inhibin and high FSH.
Yeah, so low inhibin, high FSH, slightly increased or normal LH, and a normal testosterone. That's what you will see in the cryptorchidism. Okay, because the Leydig cells are not affected. If you got a bilateral cryptorchidism, in that case, even the Leydig cells does not function, because most of the time, this bilateral cryptorchidism occur because of a loss of testosterone or the dihydrotestosterone. Remember, if you have the low level of testosterone or low level of this DST, then you won't have the descent of the testis, right?
Okay.
So a bilateral condition is generally seen whenever you have a low level of testosterone or the DST. And that means even these Leydig cells are not functioning in that case. So you will be having a low level of testosterone, high level of LH, high level of FSH, and low level of inhibin B.
Yeah.
Okay, so that's about the unilateral cryptorchidism and the bilateral one. For the unilateral one, the testosterone will be normal. For the bilateral one, because the cause is the loss of testosterone, so you will be having a low level of testosterone, high level of LH, FSH, and low level of inhibin B. Okay, now, if the patient is having a cryptorchidism, that will increases the risk of having a testicular cancer, having a risk of germ cell cancer specifically. So for that purpose, you need to remove the testis, okay?
Yes.
And the removal of testis is known as the yeah? Any doubt?
no.
Okay. The removal of testis is known as the orchiectomy, okay?
Yes.
So in order to prevent the cancer, in order to prevent the germ cell cancer, Stephen will ask you why you need to remove the testis, right? So the reason is basically to prevent the cancer in this patient, right? You will do the orchiectomy. Now, before the 2 years of age, if you diagnose the condition that the patient is having a cryptorchidism and the patient is still 1 year or maybe 1.5 years old, before the 2 years, okay, then you can perform the orchiopexy, which is basically by the means of surgery, you will cause the descent of the testis. Okay, surgically you will do that. So before the 2 years of age, orchiopexy. After 2 years of age, orchiectomy. Or is that okay?
Yes.
Yeah.
So that's about the cryptorchidism. Any doubt, please ask.
They would still have people with unilateral cryptorchidism would still have estrogen production, right? Because you can still turn
Yes.
to test.
Yeah, they will be having a normal level of testosterone, normal level of estrogen. Okay. Decreased level slightly, of course. Okay.
Yeah.
But again, remember I told you about the unilateral orchiectomy condition in the previous part we have discussed in the physiology. I told you what features you will see in the patient if you remove one testis in the patient. Remember?
Yes.
Yeah.
You decrease
Yeah.
spermatogenesis.
Yeah, the decrease. Yeah, that decrease. The formation of sperms will be decreased. The testosterone level will become normal eventually because of hyperplasia. Remember, all these feedback inhibitions will get activated. You will have a high level of this LSFSH again things, right?
Yes.
So again, same thing will be seen in the cryptorchidism again, right?
Okay. That works.
Because one testis is not functioning, one testis is only functionable. So high level of FSH will be there, low level of inhibin B will be there, a slightly reduced level of estrogen will be seen. Okay, a normal testosterone will be seen, but right. And if you remove the testis, then you're removing that testosterone by this testis, right? So again, you'll be having a initially fall in the level of testosterone that will eventually causes a feedback increase in the LH levels, right?
Yes.
So again, that will that thing we have discussed previously, that all features will be seen whenever you remove one testis in case of cryptorchidism or orchiectomy, right?
Yep. Thank you.
Any more doubt on the cryptorchidism?
No, thank you.
Okay. Then you have the testicular torsion, and it is similar to that of ovarian torsion. Okay. And I told you, you need one filament, you need some fibers, filaments, in order to in order to fix the testis with the scrotal sac. And remember the name of these filaments or ligaments?
Gubernaculum.
The gubernaculum, right? If you have a loss of gubernaculum, okay, then your testis will become very prone to the torsion, right? Because they become very unstable, right? So whenever you have an inadequate fixation of the testis to tunica vaginalis or to the scrotal sac because of loss of gubernaculum or loss of the tunica vaginalis, In that case, patient will be having an unstable testis that can lead to the testicular torsion. Okay, because of the torsion, it become a very acute, severe onset painful condition. Patient will be having a severe onset of pain in the testis, okay, in the unilateral side, okay, and the testis which become torsade. See, what happens is, if this is my scrotal sac, okay, and these are the testis in it, okay, when the torsion occurs, this initially, because this is an oval shape, right? So it has two axes, horizontal and the vertical, right? This is a
Yeah.
horizontal, this is a vertical, similar for this testis. Now, as you can see, initially the vertical this axis which is vertical, it has this high length, right? It has more length, right? But when the
Yes.
testis torsion occurs, the testis become like that. Okay.
Okay.
Yes.
So now the horizontal axis become the longer one and the vertical axis become the shorter one, right? Because of that, you will be having a high reading testis. Okay. You getting my point?
Yep.
When the testis torsides, what happens is they change their axis, and now they become horizontal instead of vertical. Now, because they become horizontal, they will appear as the high reading testis. So this patient will be having a severe acute onset of pain, a high reading testis, and the nerve will also get compressed because of this duct. What is the name of the duct? Spermatic duct, right? Because of the compression of this spermatic duct, patient will also have a loss of genitofemoral nerve, remember?
Yeah.
And because of this loss of genitofemoral nerve, patient will also have an absence of cremastic reflux. Okay.
Yeah.
So when you encounter a patient having a sudden onset of severe scrotal pain, or having a nausea, vomiting, having a high reading testis, and the absence of climatic reflex, think about the testicular torsion. Patient can also have an episodic history of pain because these fibers, these ligaments are absent. You know that sometimes patient can also have a torsion, a slight torsion, right? So patient can also have an episodic onset of pain history previously, okay? And now this pain become very severe this time because of a complete torsion occurred this time. When a partial torsion occur, patient get episodic pains, a slight pains, okay? But now because a complete torsion has been occurred, the pain become very severe this point, okay?
Yes.
So these kind of a history can also present in this patient. Now, when the testis become torsade, you will have a compression of veins because the veins are thin walled and the arteries are thick walled, right?
Yes.
So because of the torsion, when the veins become compressed, they cannot drain the blood. And just like in the ovary, you will have a normal blood flow by the arteries initially. That will cause the accumulation of the blood in the testis, right?
Right.
The blood got accumulated in the testis, the pressure will become increased. When the pressure increased, you will be having a loss of blood flow that will causing the hypoxia, ischemia, necrosis.
Yeah.
And that again will causing more pain to the patient. The patient will be having a unilateral swelling of the scrotum. So along with the unilateral swelling of the scrotum, severe acute onset of pain, high reading testis, absent of cremastic reflex, you will think about the testicular torsion. Is that okay?
Yeah.
And what kind of an infarction it would be?
Hemorrhagic infarct.
Hemorrhagic infarction. You will get a red infarct. Remember, I told you only certain locations you will get a red infarct. And one of that is the testis and the ovary, okay?
Yes.
Now, the treatment will be to remove the testis. You will perform the orthopexy, and you will also perform the contralateral orthopexy because a high risk of, the contralateral testis can become torsade, right? So a high risk is there. And in order to do that, you will also remove that testis, okay, right? So both the testis must be removed because of an increased risk of torsion in both the testis, okay?
Yeah.
So step one will ask you whether to perform a unilateral orthopexy or why to perform a unilateral or this orchectomy or to perform a bilateral type. So please note it will be a bilateral type, not a unilateral type, okay? And they will ask you why this bilateral because of an increased risk of subsequent torsion in the contralateral testis. Okay?
Yeah.
So that's about the testicular torsion. Any doubt?
No.
Okay, now you have other condition, which is the varicocele. Whenever the venous drainage got blocked, okay, you will be having an accumulation of the blood in the venous plexus of the testis. That cause and the name of that plexus is the papiniform plexus. So due to the accumulation of the blood in the papiniform plexus, you will be having a dilation of the veins, and that will give a worm of a bag-like appearance to the scrotum, to the testis, okay?
Yeah.
And that condition is known as the varicocele, okay? Now, I told you that in case of my left testis, you will be having a drainage of the blood into the left renal vein, remember?
Yes.
So any pathology which is blocking the blood into my renal vein, okay, that means it could be a RCC, it could be it could be a case of any thrombosis maybe in the veins, right? So any case which is blocking the blood flow through the papiniform plexus through these veins, the gonadal veins, or anything blocking my renal veins, that will be causing the varicocele. That will be causing an increase in the pressure in my papiniform plexus, causing that dilation of the veins, causing the varicocele. Okay. So most oftenly it will be the left side because of the increase in the resistance of the flow to the left testis, right? To the flow of the blood, to the drainage of the blood on the left side, right? So most oftenly it will be the left sided because there will be a 90-degree angle between the renal vein and the gonadal vein. Remember?
Yeah.
Okay. Now, because of increase in the pressure, because you're having an accumulation of the blood, whenever the blood is accumulated, you will be having a rise in the temperature also, right?
Right.
That's
Yeah.
why in case of any wound in the, I told you in case of in case of any inflammation, you will be having a warmth over that area. Remember, and that warmth is because of increase in the blood flow.
Yes.
Right? So whenever you have an accumulation of the blood, that will increases the temperature. And again, when the temperature is increased, you will be also having an infertility, right?
Right.
Now, because the pressure is already high in these veins, if you further increase the pressure in the abdomen, that will further prevent the drainage of blood through the testis, right?
Right.
So because of any increase in the pressure in the abdomen, this will cause a profound, you can easily palpate these vessels, okay, and this will give you a back of worm-like appearance. So whenever you perform the Valsalva to the patient and you examine the testis, you can find this worm of a bag-like appearance in the testis, and that's how you know that the patient is having a varicocele. So this condition is always augmented by the Valsalva. Okay.
Yeah.
Now tell me, this condition is more profound when the patient is standing or more profound when the patient is lying down?
Standing.
Standing, because of the gravity, right?
Yeah.
Because whenever you are standing, the blood has to be drained against the gravity. But when you are lying, you do not require any gravity, right? You don't need to perform any work against the gravity. So whenever the patient stand up from the supine position or from the lying down position, the patient will have this increase in the worm of bag-like appearance, right? This condition become very much profound whenever the patient is standing up. And that is again an examination that you perform. Okay. So the scrotal mark this mass will become very much profound whenever the patient is standing up from the lying down position. Okay. Should I repeat it again?
No.
Okay. So two examinations for the varicocele. One is the Valsalva. If you perform the Valsalva and the mass is increased, that means it could be a case of varicocele. If the mass is increased on the standing, that will again give you a hint that the patient is having a varicocele. Okay, the mass will be of a worm of a bag-like appearance. You will see that happening because of a blockage of the blood flow to the veins, draining of the blood flow to the veins, right? And please note that this mass does not transilluminate, and most oftenly this mass is left-sided. So these are the 3-4 things that you must remember for the varicocele. And because the temperature is increased because of accumulation of the blood, you will be having an infertility also. So that's about the varicocele. Any doubt, please ask?
No, thank you.
So any doubt on any of the topic on this page?
No, thank you.
You have the extragonadal germ cells tumor which are arised from the midlines. Okay, they could be in the retroperitoneum area, they could be in the mediastinum, they could be in the pineal areas, they could be in the suprasellar regions. Okay, remember about the pineal gland tumor? Remember pineal gland tumor? I told you it is germ cell tumor of the brain, right?
Yeah.
Why? Because this tumor releases the HCG and this tumor has a histology feature just like the seminoma. Remember, the fried axle appearance would be seen there,
Yeah.
right? So these kind of a tumors, you will call it a extragonadal germ cells tumor. The germ cells tumor of brain is known as the pineal gland tumor, right? Same
Yeah.
kind of a tumors can be arise in the mediastinum, in the retroperitoneum, in the suprasellar regions, and again you will call it a extragonadal germ cells tumor. So nothing much important about this. Just know about the pineal gland. Most important thing is that, okay? Now you have these scrotal masses. Many type of scrotal masses could be there. It could be a cancerous lesions. It could be a benign lesion also. Okay. Benign lesions are most oftenly transilluminated, while the cancerous lesions are not transilluminated because they are solid, right? If you shine a torch on a solid mass, it won't transilluminate, right?
Right.
But if you shine a light on a mass which is filled with a fluid, it will transilluminate.
Yes.
Yes. So whenever the mass is transilluminating, that means it must be a benign mass, not a cancerous mass. So the first condition is the congenital hydrocele. I told you, whenever you have an improper closing of the inguinal rings, or whenever you have a persistence of the what layer?
Vaginalis.
What vaginalis?
Processes vaginalis.
Processes. You won't call it a tunica vaginalis, okay? Because a tunica vaginalis always occurs whenever the processes vaginalis become obliterated, right? Because the
Right.
processes vaginalis are still present, you won't call it a tunica vaginalis. Okay, so now whenever you have an incomplete obliteration of the processes vaginalis, you will have a continuous, you will have a connection between the peritoneum and this part, right? And as a result, the fluid will start accumulating inside this layer that will cause a swelling in this testis, as you can see, right? A fluid will be filled within this layer. So whenever you shine a torch, this mass will transilluminate, right?
Yes.
So this is the congenital hydrocele. You will see a testicular swelling, you will see a scrotal swelling. You will shine a light, and when the light is shining, you will see that this condition is a congenital hydrocele. Second is the acquired hydrocele. It can be happen because of any infection. Whenever you have the infection, you have the edema, right? Because of an increase in the permeability of the blood vessels. Remember?
Yes.
So when the permeability of the blood vessels is increased, you will be having an accumulation of the blood inside the scrotum, and that again can lead to the acquired hydrocele. Most often, because it is a blood, it will be the bloody kind of thing. Hematocele will occur. Okay. Then you have the spermatocele, and as the name suggests, you will be having a cystic dilation of the epididymis or the retitestis because they contain the sperms, right? They are the sperm ducts, right?
Yes.
So in this case, you'll be having a swelling of the epididymis or the retitestis. As you can see, this kind of a swelling is present in the spermatocele. And this will present as the fluctuating nodule. Sometimes you have the swelling, sometimes you have the resolution from the swelling. And again, the swelling will come back. So if you see a patient who is having an episodic swelling, think about the spermatocele. They will ask you what is present inside this swelling. So these will be the sperms. Okay, these ducts will be filled with the sperms. So in these cysts, what is present? It will be the sperm. So, okay.
Yes.
Other two conditions we have discussed already. The testicular torsion, as you can see, the testis will become very high riding in case of torsion. A varicocele, you'll be having a scrotal mass, which is a worm of bag-like appearance. Okay. So please note, a non-transilluminating mass can be a varicocele also, not just a cancer. Although most of the times, whenever you see a non-transilluminating mass, it will be the cancer. Okay. But please note, you will also need to check for the this thing also, the varicocele also, because it is again a non-transilluminating mass. Okay.
Could you repeat it once? I lost my connection.
See, I told you for a testicular tumors, see this line, whenever the mass is transilluminating, it is always be a benign condition. And whenever the mass is not transilluminating, that means it could be a case of solid testicular tumors, right?
Right.
But you also know that the varicocele is also a non-transilluminating mass, right?
Right.
So whenever you see a patient having a non-transilluminating mass, you cannot just diagnose them with the cancer. You need to check for the varicocele also. For that, you perform two examinations. One is a Valsalva and second is a standing up position, right?
Right.
If the mass is increasing with the Valsalva, if the mass is increasing with the standing up, that means it is a varicocele, not a cancer. Okay.
Yes.
And testicular torsion, again, you will be having a very painful condition. High rating testis will be there. Loss of blood flow will be there. Accumulation of blood will be there. Okay. Blood-filled testis is present ultimately, right?
Yes. Thank you.
So these are about all the benign masses. Now comes the testicular tumors. Whenever you see a patient having a very solid mass in the testis, you will always think about the testicular tumors. Okay, very important. You will always think about the testicular tumors, and these masses, they does not transilluminate. Again, that will give you a hint that the patient is having a testicular tumor. And whenever you see a scrotal mass, a solid scrotal mass, you cannot perform the biopsy in the patient. Please note, you cannot perform the biopsy because of increased risk of the seeding or the metastasis. So whenever you see a testicular solid mass, the first thing that you will perform is to remove that mass, is to remove the testis completely and then to check the lymphatics of the patient. Is that okay?
Yeah.
So the risk factors for the testicular tumors are the cryptorchidism. I told you, whenever you have a patient with the cryptorchidism, the patient can have a germ cell tumor. Klinefelter syndrome, if you go back, you will see that Klinefelter syndrome can have a complication of the testicular tumors, right?
Right.
So germ cell tumors are the most common type. They're around 95% of the times. The patient will be having a germ cell tumor. Again, they will be a solid mass. Okay, they do not transilluminate. And whenever you see a solid mass in a tumor, you will always remove it without any biopsy. Okay. Second type of tumor will be the sex cord stromal tumor. Okay, which is a tumor that arises by the Sertoli cells or the Leydig cells, right?
Right.
Again, the theca cells and the granulosa cells in the females, remember? These type of tumors can also happen. So a Sertoli cell tumor, Leydig cell tumor, granulosa cell tumor, theca cell tumor, you will call it a sex cord stromal tumor. Is that okay?
Yes.
And these are around of 5% of the tumors. And most oftenly, whenever you see these tumors, they are most oftenly benign. So just remove the mass. You won't need to worry about that later. So if the tumors are arising from the sperms itself, okay, from the developing sperms, from the oogonium, remember, from the oogonium, you will start the journey,
Yeah.
right? So tumors could be arise from the sperms, from the oogonium, from the oocytes. Okay, you will call it a germ cell tumor. When the tumor arise from the Sertoli cells or from the Leydig cells, you will call it a sex cord stromal tumor. Okay, the patient will be having a, whenever they have a cancer, patient will always present you with a unilateral testicular heaviness because there is a mass, so mass symptoms will be present, right? And the mass has a weight. So the patient will also, the patient will always present you with a painless testicular mass, a testicular heaviness will be, right? That mass won't transilluminate. And whenever you see this kind of a presentation, you will always remove the testis, okay?
Yes.
So that's about the generalized view of all these cancers. Any doubts so far?
No, thank you.
So let's take a short break and then discuss all these cancers, okay?
Okay. Yeah.
Okay.
Okay, so testicular tumors, you have two types, the germ cells tumors and the sex cord stromal tumors. Germ cells tumors are again of two types. Okay, the one is the seminomatous tumor and second are the non-seminomatous tumor. Okay, so the seminomatous tumor includes the seminoma. Okay, and it is a highly malignant tumor and it is a male counterpart of female dysseminoma. Okay, and it is you can say that it is a analog of the ovarian dysseminoma. And similarly, you can find this germ cell tumor in the brain also. That is an analog of the seminoma in the brain, and that is a pinealoma, right?
Right.
On the histology feature, you will again have a similar to that of reticulomelanoma. You will have the fried-egg appearance of the cells, right? And this tumor releases the placental alkaline phosphate. Okay, LDH will be there. Placental alkaline phosphate will be there whenever you have the seminoma. So a patient who is having a solid testicular mass, as soon as you see that patient, you will have to remove that mass without any diagnosing that condition. You will remove that mass. You visualize it under the microscope. What you will see that the patient is having a fried-egg appearance of the cells. And on the lab examination, what you will find that the patient is having a high level of alkaline phosphate. And that's how you know that the patient is having a seminoma. Is that okay? Yeah. Other than that, fibrous septas and and these lymphocytes can also be seen, because whenever you have a cancer, the lymphocytes will try to act against it, right? Yeah. So lymphocytes can also be seen in the histology if you perform, okay? So these are the things, and please know that it has a very excellent prognosis. Although this condition is malignant, this condition still has a very excellent prognosis. So a painless, homogeneous testicular swelling will be seen, okay? No hemorrhage, nothing, okay? It's just a painless, homogeneous swelling will be there. Then you have the teratoma, and I told you in case of females, the teratoma is benign, right? And I told you that in case of males, the teratoma is always malignant. Okay. Yes. And just like the females, it has again 3 layers: ectoderm, mesoderm, endoderm. All the tissues are derived from these layers. You will have hairs, teeth, sebaceous glands, adipocytes within the testes. You will call it a teratoma. Okay. Okay. Yes. Then you have the non-seminimatous germ cells tumor. You have 3 types: embryonal carcinoma, yolk sac tumor, and choriocarcinoma. Okay. Now, for the embryonic carcinoma, it would be a painful hemorrhagic mass with necrosis. So a painless homogeneous mass, seminoma, a painful hemorrhagic necrotic mass, think about the embryonal carcinoma. Now, as soon as you see this kind of a mass, you will remove it again. And when you remove it, you will have to check for other labs of the patient. In the labs, you will check for the HCG levels and you check for the alpha fetoprotein levels. Patient can be having a high level of alpha fetoprotein and a high level of beta HCG. In that case, you will call it a mixed type tumor. When both the levels are high, you will call it a mixed tumor. When only the beta HCG levels are high, but a normal alpha fetoprotein level is present, you will call it a pure embryonal carcinoma. Okay? Yeah. Because most of the times, whenever you have a testicular tumor, this kind of a mixed type tumor. So multiple tumor markers could be raised, like the alpha fetoprotein, the HCG, okay, the LDH, alkaline phosphate, and many other things, right? Whenever you have a mixed kind of a tumor. But whenever you have a pure tumor, for example, a pure seminoma, alkaline phosphate will be high. Whenever you have a pure embryonal carcinoma, beta HCG will be high. Whenever you have a pure yolk sac tumor, alpha fetoprotein level will be high. But whenever you have a mixed tumor, all these levels will be high. Is that okay? Yes. So in case of embryonal carcinoma, again, if you have a pure embryonal carcinoma, then only HCG levels will rise. If you have a mixed kind of a tumor, it will both alpha fetoprotein levels as well as the beta HCG. Of course, this condition is more worse than the seminoma, so patient will have a worse prognosis again. Okay, so that's about the embryonal carcinoma. Then you have the yolk sac, or you can say the endodermal sinus tumor, which is seen again in the children. Just like in the females, you will have the skeletal bodies or the glomeruloid bodies you will see. This tumor, again, just like the females, will release the alpha fetoprotein. So if it is a pure yolk sac tumor, you will have only the alpha fetoprotein level rise. If you have a mixed tumor, you will have both the alpha fetoproteins as well as the HCG level rise. Okay. Okay. Yes. So on the histological features, what you will see are a central vascular core, which is surrounded by the tumor cells. Okay, and on the cross examination, this tumor will be a yellow mucinous mass. Okay, then you have the choriocarcinoma, just like the female, the choriocarcinoma, it will be arise from the trophoblast. You will have a disorganized syncytophoblast and the cytoplastic elements. This tumor, just like in the females, will metastasize to the lungs, to the brain, causing a cannonball metastasis. This tumor, just like the females, will release that high level of HCG. Okay, patient can have a hyperthyroidism. Patient can have a gynecomastia. Okay, because the alpha subunit can mimic the LH, FSH, and TSH. Okay, that's about the choriocarcinoma. Any doubt?
No, thank you.
So all are just the male counterparts of the female carcinoma. Same features, everything will be same. You encounter a mass. That mass could be homogeneous diffuse normal. This mass could be a hemorrhagic necrotic mass. This mass could be a yellow mass. This mass could be anything. Based on the gross features, based on the histology, you will differentiate the different type of cancers. You will see the tumor markers of the patient, beta HCG, alpha fetoprotein levels, LDH levels, alkaline phosphate level. Based on which protein level is high, which tumor marker level is high, you will diagnose these conditions again. Now you have the non-germ cells tumors, or you can say the sex-part stromal tumors. These are the Sertoli cell tumor first. Okay, and again you will be having the proliferations of the Sertoli cells. You will be having a high level of estrogens in these tumors, right? High level of androgens will be there, and that will again convert into the estrogen. So high level of testosterone, high level of estrogen will be there, right?
Yeah.
In case of Leydig cell tumor, this tumor will be releasing high amount of androgens that again will be converting into the estrogens. So if it is a teen patient who is not still in the puberty, before the puberty, if the patient got a Leydig cell tumor, then he can have a precocious puberty, right?
Yeah.
And then again, an adult male or maybe a puberty male can have the gynecomastia also.
Yes.
Okay. So a precocious puberty and the gynecomastia, these are a very highly characteristic features of this Leydig cell tumor. Okay. And within the cells, you will find some eosinophilic crystals. In case of Leydig cell tumor, you will call it a Ranke's crystals. Okay. Although you won't need to see this, just know that the patient would be having a gynecomastia and the hyperandrogenism in this case. Okay. Then you have the testicular lymphoma. And again, it is a lymphoma. That means you'll be having a lymphocytes, right?
Yes.
And that again arises from the lymphoma anywhere. Okay, when you have the lymphoma in any other tissue and the metastasis of this lymphoma occur, it will reach to the testis and it can cause the lymphoma of the testis, right?
Right.
So this condition is because it is lymphoma, it is already present in the blood vessels. So this condition is always a malignant condition, right?
Right.
So these are the primary cancers, and this cancer is a metastatic, or you can say a secondary cancer of the testis. Any doubts so far?
Why is teratoma malignant in boys?
Well, that's kind of a research stuff, so I really have no idea.
Okay, that's fine. Thank you.
Yeah. I need to do the PhD in this case. So when I do that, I will tell you, okay?
Okay.
Okay. So now you need to know about the hormonal levels, the placental alkaline phosphate, alpha fetoprotein levels, beta HCG again. In case of seminoma, you will be having a high level of alkaline phosphate or a slightly raised level of HCG. In the yolk sac tumor, alpha fetoprotein levels will be a characteristic feature. Choriocarcinoma, HCG levels will be very much high. Teratoma, nothing, nada. In case of embryonal carcinoma, if it is a pure type, only HCG levels will rise. If it is alpha fetoprotein levels and both HCG will rise, that means you are having a mixed tumor, right?
Yes.
And most of the times it would be a mixed tumor. You will see a solid hemorrhagic necrotic mass and both the levels are high. So you know that this tumor is originating from both my yolk sac as well as from my embryonal cells, right?
Yes.
So our mixed tumor will have the component from all of the above tumors. Seminomatous component will be there, trophoblastic component will be there, and a yolk sac component will be there. So all these levels will be raised. Any doubt on this page?
No.
No.
Okay, now you have the inflammatory conditions of the epididymis. You call it a epididymitis. Okay, and the inflammation of testis is known as the orchitis. Okay, both of these conditions occur whenever an infection happens. Okay, in the old age, the most common cause of infection is the E. coli and the Pseudomonas. In the young patient, adult patient, okay, the most common cause is a chlamydia trachomatis and the Neisseria gonorrhea, because it happens always after the sex. So it is a STD condition, right?
Yeah.
So STD conditions in case of adults. In case of old age, it could be due to the E. coli and could be due to the Pseudomonas. So when the patient is having a chlamydia trachomatis or a Neisseria gonorrhea infection, epididymitis, can the patient also having a discharge from the urethra?
Yes.
So a history of discharge is always present whenever the patient got a chlamydia and a gonorrheal infection, okay, along with the features of epididymitis. That will help you diagnosing this condition, okay. So whenever you see a discharge in a young patient, along with the epididymitis features, you will think about the chlamydia and the Neisseria. When you see only the features of epididymitis, no discharge in the old age patients, that means this could be a case of E. coli or the Pseudomonas, okay.
Yes.
Now, in order to have this condition, the elderly patient must be having a trigger point, right? A trigger must be there. This could be a blockage. For example, in case of a BPH patient, this could be a case of UTI. And after the UTI, patient got this epididymitis, right? Or orchitis maybe. Okay.
Yes.
So a trigger is always there in case of elderly patient. Now, in case of these young patients, okay, to diagnose this condition, you will perform a NAT score. And does anyone remember the full form of this NAT?
Nucleic acid amplification test.
Yeah, you will perform a nucleic acid amplification test, and as a result, and as the name suggests, a nucleic acid amplification, you will be amplifying the DNA of the microbes, right?
Yeah.
You will amplify the DNA of the microbes. You will see whether the microbes are present or not. On the urine culture, if it is a case of chlamydia specifically, you will see only the neutrophils or WBCs. Okay, no bacteria will be seen. In case of gonorrhea, sometimes you can see the bacteria, sometimes you cannot see the bacteria, and you will call it a pyuria conditions, right?
Yes.
Sterile pyuria, remember?
Yep.
Now, let's discuss the epididymitis. It is basically the inflammation of the epididymis. Okay, whenever you have the epididymitis, you will be having a pain on the posterior and superior aspect of the testis. Okay, so whenever you encounter a patient having a unilateral superior and posterior pain on the testis, you will think about the epididymitis. Okay.
Yeah.
And when you elevate the testis with the hands or the scrotum with the hands, you will get a relief of pain in the patient. Okay, so whenever you encounter a patient having a posterior and superior pain on the unilateral testis or scrotum, and by elevating this scrotum, the pain is gone, you will think about the epididymitis. If it is a young patient, most chances are that this condition could be caused by the chlamydia or Neisseria. If it is an old age patient, chances are this condition could be caused by E. coli or Pseudomonas. Vital signs in the patients are totally normal. BP will be absolutely normal. No fever is present. It's just a unilateral testicular pain is present. Okay.
Okay.
Second condition is the orchitis. The most common cause of the orchitis is the mumps. Remember, and the mumps you can have a orchitis, pancreatitis, meningitis,
Parotitis.
parotitis. Yes, right.
Yeah.
So orchitis will appear as a diffuse testicular pain. So if a localized pain is present on the posterior superior aspect, it is the epididymitis. If a diffuse pain is present, that means it is the orchitis. If it has happened with the mumps orchitis, the patient will be having a history of parotitis also. The patient could be having a history of pancreatitis also. It would be a child who is not vaccinated yet, right? Because after the vaccination, you cannot have the mumps, right?
Right.
So patient will be having no history of the vaccination, then only you will suspect the mumps orchitis. Other than that, chlamydia, Neisseria, E. coli, Pseudomonas, they all can cause the orchitis in the adult patients and in the old age patients, right? Now, if you got a orchitis, in case of mumps orchitis specifically, you will also get the fevers, right? So vital signs will be abnormal again in case of orchitis, while the vital signs are totally normal in case of epididymitis.
Yeah.
Okay. So this is the differentiating features between the epididymitis and the orchitis. So you will either encounter a diffuse pain or a localized pain. You will either encounter a young patient or a adult, or a old age patients. So based on the history of the patient, you will see whether it is caused by Neisseria, gonorrhea, or whether it's caused by the E. coli Pseudomonas, or whether it is epididymitis or the orchitis. Okay. Any doubt?
No.
No, thank you.
I want to know the concept, like why when we elevate scrotum pain relief, like the
Why we elevate the scrotum and the pain is relieved? We have no idea about that.
okay.
Sorry to say.
Maybe just relieve the compression on the infected tissue.
It could be. I'm really not sure about that. Why this pain is gone after the elevation?
Okay.
Could be the case. You can search on Google. Okay, someone and type in the chat box. You can type it down. Okay, so that everyone can see. Okay,
Okay, thank you.
someone can do that. Okay, now you have the BPH, which is the benign prostatic hyperplasia. See, it is the hyperplasia, not the hypertrophy. Okay, you might get confused with the hypertrophy. So it is not the hypertrophy case, but it's the hyperplasia case. In this case, we'll be having the hyperplasia of the parenchyma of the prostate gland. Okay. Now, as a result, you will be having an increase in the number of lobules, in the number of glands, right?
Yes.
Now, in a prostate, you have two components. One is the gland component, or you can say the epithelial component, which is the actual glands. Okay. And second is the stromal component, right? Which contain all the blood vessels, smooth muscles, collagen, right?
Yeah.
So when the BPH is happening, you will have the proliferation of both the epithelial component as well as the stromal component. Okay.
Okay.
Other thing is, now, depending upon what component is being, in what component you are having a hyperplasia, you can give the drug accordingly. If you are having a hyperplasia in the epithelial component, then it is under the direct regulation of the DST, right? So you can give the patient finasteride. So if the step 1 asks you how this finasteride is working here, so please note it will cause the atrophy of the epithelial component in the BPH. Okay.
Yeah.
For the stromal component that contains the smooth muscles, you need to give the patient a smooth muscle relaxant, right? For example, the alpha-1 blocker, because I told you the alpha-1 receptors are present there, right?
Right.
So if you so if you block the alpha-1 receptors, you will have a relaxation in the stromal component, right? And
Yes.
that's how the alpha-1 blockers work in case of BPH.
Okay.
Now, again, you have 3 zones in the prostate. One is the central zone, second is the peripheral zone, and third is the transitional zone, or you can say the periurethral zone. Okay, this is a urethra, as you can see, and the zone which is surrounding the urethra, it is the periurethral lobe or zone, right? Then you have the peripheral zone where the cancer arise, and you have again the central zone, which is basically surrounding the ejaculatory duct. Okay.
Yeah.
Now the BPH arises from the periurethral zone, or you can say the transitional zone. That means this is a urethra. Around this urethra, you have the peripheral zone. You have the periurethral zone, right? Or the transitional zone. From this area, the BPH arises. And when the BPH arises, it will compress the urethra, right?
Yes.
So patient will always present with the early symptoms of the obstruction. Like the patient will be having a weak urinary stream. Patient will be having a history of incontinence, overflow incontinence, right? Remember?
Yeah.
So overflow incontinence will be there. Weak urine stream will be there. Patient will have a problem with starting and stopping of the urination. Okay. So initially they have a problem with the starting of the urine. They cannot start the micturition. But once they started the micturition, they cannot stop it. Okay.
Yes.
So they tell you that they're having a problem with the micturition. They have a problem with the starting and stopping of the urination. They have a very weak urinary stream. They will have a continuous dribbling of the urine. Okay, these kind of a history will suggest you that the patient is having a blockage in the urethra. And in male, it is of course really caused by the BPH. Right?
Yes.
Now you will have a smooth enlargement of the gland in case of BPH. Okay, that is again an important thing. Although sometimes you can have a nodular enlargement, but please note most of the time a diffuse enlargement is there, not a nodular type. Okay, if you see the nodules, then most chances are that this condition is a cancer, not a BPH. Okay, while if you have a smooth enlargement, that means chances are that this condition will be a BPH. If a firm enlargement is there, a hard enlargement is there, chances are that this condition is a cancer. So a hard condition with nodules, cancer. Soft condition with a diffuse enlargement, BPH. Okay.
Yeah.
Remember that thing also. And yeah, so enlargement is because of the parietal zone. Okay, you will have an increased frequency of the urination. Nocturia will be there because of incomplete emptying of the urinary bladder. Patient will be having a difficulty in starting and stopping of the urine. Weak urine stream will be there. Dysuria will be there. Okay, now because of the blockage, the pressure before the blockage will be increased. That means the pressure in the bladder will be increased, right?
Right.
So patient will be having a hypertrophy of the bladder because of that. Okay, now because of this hypertrophy, you're going to also have the angiogenesis, right? To provide the blood flow. To increase the blood flow for the hypertrophy of my bladder, you need the angiogenesis, right?
Right.
So new blood vessels will also form in the bladder that will become a very fragile vessels. And because these vessels are again fragile, similarly in case of my BPH, new vessels are also being formed, right?
Yes.
So both in the bladder as well as in my BPH, in my prostate, I'm having an angiogenesis. And because of that angiogenesis, because these vessels are kind of very much weak, they will rupture, they will have a leakage of the blood. And as a result, patient can also have a hematuria sometimes.
Yeah.
Okay. So if they ask you why this hematuria is present, it is because of the angiogenesis, formation of a new blood vessels. Okay.
Yes.
In the bladder, when you perform the cystoscopy, what you will see in the bladder, you will be having an increased trabeculations of the detrusor muscles, right? Because of the hypertrophy. Hydronephrosis can also happen. I told you already in the previous chapter, right?
Yes.
Because of the blockage, patient can also have an infection in that. So UTI will be increased, epididymitis can happen, orchitis can happen, right? And the causes are the E. coli and the Pseudomonas, remember?
Yeah.
Okay, now in auto-diagnosis condition, you can check for the PSA levels. A slightly increased PSA levels will be there in case of BPH, while a severe increase in the level of the PSA suggests the cancer, okay? So a
Yes.
moderate increase in the PSA levels means the hyperplasia. A severe or a heavy increase in the PSA suggestive of a cancer. Treatment include the given patient alpha-1 antagonist. I told you they will act on the stromal component. Tamsulosin, alphalusin, prazosin, triazolin could be given, right? Second are the 5-alpha reductase inhibitor that act on the epithelial component, preventing the hyperplasia of the epithelial component. And these are the finasteride. PED5 inhibitors could also be given, which causes the vasodilation, could causes the smooth muscle relaxation, tadalafil, for example. Surgical resection can also be done. On the rectal examination, you will see a smooth and large prostate gland. Okay. Smooth word is very important. Diffusely enlargement is very important. Sometimes you can have a nodules, but again, these nodules are smooth. If you found a hard nodule or a firm nodules, it will always be a suggestive of cancer. Okay.
Yes.
So any doubt on the BPH?
No.
No, thank you.
Here, the form nodule enlargement, it suggests in the central zone or in the peripheral zone.
In the central zone. See, eventually what happens? Initially, you will only have these compression symptoms. Initially, you will only have the compression of the urethra. But as the disease progresses, you will have the involvement of other zones also, right? It starts in this zone and then progresses, right?
So when it writes the form nodular, then when we do the rectal examination to check the prostate, the smooth, irregular, or how it is. So in
Sorry, I
that,
didn't understand what you are saying. Ask it again, please.
I mean
Speak
the
loudly, please.
yeah, I mean the when we do PR rectal examination, and if there is a form nodular things comes to our on examination, so it confused with the CA prostate, isn't it?
It confused with the prostate.
Cancer, prostatic cancer.
See, most of the times when you see a nodular enlargement, it will be a cancer, right?
Yeah.
High chances are that it is a cancer, not a BPH. If you see a smooth enlargement, then chances are that it is a BPH, not a cancer.
Okay. No.
Is that your question?
Yeah, I mean to say that I couldn't understand here mentioning the form nodular enlargement.
Form nodular enlargement, it means a hard nodular enlargement. You're not, you're asking about the mechanism, right?
No, I'm asking the meaning. Why the nodular enlargement? Nodular means some nodular, irregular.
Yeah,
right?
some nodules are present. Yes, nodular enlargement means some nodules are present. See, in case of cancer, you have some localized growth initially, right? So they will form the nodules more likely. In case of my BPH, because it is a hyperplasia, it is start in this complete region and then progresses, right? So a diffuse involvement will be there. So most of the times it will be a diffuse enlargement and a smooth enlargement. While in case of my cancer, because a certain cell or certain area of the tissue will be involved first only, right? So that will form a nodule, a cancerous nodule. So most oftenly, nodules are found in the cancers.
Yeah, that's what I mean to ask.
Yeah. Okay. So that was about it. Initially, you have the compression symptoms, and then you will have the symptom, the diffuse enlargement. So, if you perform the rectal examination, you can even get a negative test, because initially you won't have, the involvement of the prostate that can cause, the bulging of this tissue into the rectum. So initially you can have a negative rectal examination, but a positive urethral symptoms. While in case of my cancer, at a very initial, I will get this examination positive without any urethral symptoms. Okay.
Thank you. Thank you.
So any more doubt on the BPH?
No, thank you.
No, thank you.
Okay, now you have the prostatitis, which is the inflammation of the prostate gland. Again, when you have a urethritis, the infection can travel upwards, retrograde, and it can reach to the urethra, it can reach to the prostate, it can reach to the urinary bladder, it can reach to the epididymitis, it can reach to the testis also, right? So after the urethritis, after having STD, this infection can go anywhere, right?
Yeah.
And again, it can cause some symptoms like the epididymitis, orchitis, prostatitis. So prostatitis is basically the inflammation of the prostate glands. In young adults, it is caused by the chlamydia and dysuria because of a STD. In case of older patients, it is caused by a blockage like the BPH, like the UTI. Okay, and that will be seen with the E. coli. Okay, patient will be having a dysuria, which is very painful micturition. Again, a symptom of urethritis. Frequency, urgency will be there. Pelvic pain or a lower back pain will be there, and the patient, the prostate become very much warm and tender. So fever, chills will be there in the patient's systemic signs and symptoms of the inflammation. Fever, chills, a warm and tender prostate will be there, lower abdominal pain. Okay, frequency, dysuria, painful micturition will be there. These all are the symptoms of prostatitis. Okay, a chronic prostatitis could be a bacterial, could be a non-bacterial. It could be due to a chemical irritation, could be due to a nerve problem, right? It could be due to a recurrent infections also. So you both have the acute inflammation as well as the chronic inflammation. In the acute inflammation, you will see the neutrophils. In case of chronic inflammation, you will see the lymphocytes, right?
Yeah.
So that's about the prostatitis. Any doubt? Simple thing.
No, thank you.
Now you have the prostatic adenocarcinoma, and it is always seen in the males who are having an age more than 50 years. It is always seen in the old age males. And please note, it arises from the posterior lobe, or you can say a peripheral zone, which is present just anterior to the rectum. Okay, posteriorly you have this rectum here, and anteriorly you present this peripheral lobe, okay, or the posterior zone where the cancer arises. Okay.
Yeah.
Now, because as you can see, this cancer is present just anterior to my rectum. Whenever the cancer is happened here, it will project inside the rectum, right?
Yeah.
So if this mass is projecting inside the rectum and I perform the rectal examination, okay, I can see this cancer there, right? I can see this the bulging of my rectum there, right? And that's how I know that the patient is having a cancer in the posterior zone. And please note, on the day rectal examination, you will find a firm, or you can say a hard, non-tender nodule. Okay, a hard, non-tender nodule or multiple nodules could be there. So whenever you encounter a patient on the DRE, the patient is having a multiple hard nodules, you will always think about the prostatic adenocarcinoma. Patient will be having a very high level of the PSA. A severe increase in the level of PSA will be again a diagnostic for the adenocarcinoma. Okay. In order to completely diagnose this condition, you will take multiple core needle biopsies. Okay. You will progress via this rectal route, and via the rectal route, you will take the multiple biopsies from this peripheral lobe. Okay. From this posterior lobe. Okay. You will take the multiple biopsies. You will analyze each biopsy independently in the microscope. And by analyzing the microscope, we will check for the NC ratios, the nuclear atypia, okay, and the cellular differentiation. And based on your observations, you will give a score to each biopsy. And then you will add the score of each biopsy. When you get a very high score, that is a suggestive of a very poor prognosis. If you get a low score, that means you're having a very good prognosis. Is that okay?
Yes.
So how would you perform the biopsy? Via rectal route. Multiple core biopsies will be taken via rectal route. You will analyze each biopsy. You will give a score to each biopsy, and then you add the score. The highest two scores will be added. For example, you perform the biopsies and you find the highest scores are 3 and 4. Then you add the 3 and the 4, you will get a score of 7, right?
Yeah.
So that's how you do the grading of the cancer. And this grading system is known as a Gleason's grading system. Okay.
Yeah.
So note about that also. Okay. So now when the metastasis of this cancer occur, it will reach to the bones. In the bones, see, in most of the cancers in the bone, you will get a osteolytic lesions, right? You will get a resorption of the bones. Yes.
Yeah.
In case of my prostatic adenocarcinoma, you will get the osteoblastic metastasis. You will see the formation of the bones. So when you perform the X-ray of the patient, you will see the formation of new bones. Okay. And that's how you know that this is an osteoblastic metastasis. And please note, the metastasis to the bones will happen through the venous plexus. You will call it a vertebral venous plexus or the Bateson's plexus. Okay. Stephen will ask you how the metastasis to the spines will occur. So please note, it will be due to the Bateson's or the vertebral venous plexus. Okay.
Yes.
And whenever the osteoblastic metastasis occur, you will have a high level of alkaline phosphate as well as high level of PSA. Okay. While the level of calcium, phosphate, PTH, everything is absolutely normal. Okay. Just the increase in alkaline phosphate and increase in the PSA you will see. Now, do you guys remember any other cancer where you have the osteoblastic metastasis?
Breast.
Breast cancer can do that. Yes. Any other?
Kidney, thyroid, lung.
Kidney, thyroid, lung, you will have a osteolytic metastasis. Bone resorption will be there.
Oh, I thought it was PB kettle, right?
That was the frequency, or you can say the chances that these cancers will metastasize to there, right? Most oftenly, you will have, the metastasis there in the bones.
Oh,
So
okay.
that's just for the metastasis, not the not the categorization. Hodgkin's lymphoma, breast cancer, and your prostatic adenocarcinoma, they will cause the osteoblastic metastasis, while the remaining cancers will cause the osteolytic metastasis. Okay.
Could you repeat it once?
This prostate cancer, breast cancer, and the Hodgkin's lymphoma, they will cause the osteoblastic metastasis. Okay, you will see more whitish lesions on the X-ray.
Right.
Because you're having a blast, you have a more calcium. So whitish lesions will appear on the X-ray of the bone, right? If you have a osteolytic metastasis, you will have a blackish lesions on the bone, right?
Right.
That is basically a sign of resorption. So this is how to differentiate between the osteolytic and the osteoblastic metastasis on the X-ray. If more whitish lesions are present, blastic. If more blackish lesions are present, lytic. Okay.
Yeah.
So that's about the prostatic adenocarcinoma. Please note where does it arises, from the posterior lobe and from the peripheral zone. Because they're present just anterior to my rectum, you will have a projection of these cancer into the rectum that will be detected by the data this examination. You will take multiple core biopsies via DRE and endoscopic guided examinations. Endoscopic guided biopsies they are. You will perform multiple biopsies, examine them, give them a grade. Highest two grades will be added, and that will be a Gleason's grading system. Okay, and the metastasis often occurs to the vertebra via the Bateson's plexus. Patient will always complain you with a lower back pain. So a patient having a lower back pain, okay, having a high level of PSA, having a positive DRE, think about the prostatic adenocarcinoma. Okay.
Yes.
Now, any doubt, please ask.
No, thank you.
Now tell me, in order to check for the TNM staging, where should I perform the lymph node dissection? To check whether the tumor has metastasized or not, where should I perform the lymph node dissection in case of my prostatic adenocarcinoma?
External and internal iliac lymph nodes.
Iliac lymph nodes.
Okay, yeah, good. Iliac lymph nodes, right? So that's where you perform the biopsy. External or internal?
Internal.
Think about it again. I think it was external. I'm not sure. Let me check it. Just give me a second.
No, it's internal.
Yeah, it was internal. Okay. Yeah, you're right. It was the internal iliac lymph nodes. Okay. So there you will perform the biopsy. You will check whether the lymph node involvement is there or not. Okay.
Yeah.
So that was all about it.
How will perform it intraoperatively, right?
What?
How will perform that biopsy?
Biopsies, lymph node.
Yeah, so it will be intraoperatively, right?
Yeah, of course.
That's right. It's okay.
Yes, you're right. So please note, FNA cannot be performed in case of these cancer, right? FNA will be performed in case of BPH. While in case of cancers, you need to perform the whole biopsy, right?
You mean the prostatic adenocarcinoma?
Yeah. Yeah, I'm asking. Yeah, in case of adenocarcinoma, you cannot perform the FNA. FNA is for the BPH. Okay, I told you that BPH you will perform the FNA first, the fine needle aspiration, right?
Yeah. So true cut.
On the fine needle aspiration, you will check whether the glands are increased in number or not. If the glands are increased, a crowded glands are there. That means it's a case of hyperplasia, right?
So how we will do the? Okay, so we'll perform
I
the.
told you how to do the biopsies, right? Multiple biopsies. Remember?
Yeah. That's the Gleason scores.
Yeah, exactly.
Yeah.
So in case of cancer, you need to perform the biopsy because you need to check the architecture of the tissue, right?
Yeah.
Only then you can say whether it is a cancer or not. In case of my BPH, you just need to visualize the number of glands is there, how many number of glands are there, right?
Mhm.
So FNA works for the BPH, but a biopsy should work for the adenocarcinoma. FNA does not work for the these cancers, right?
So what is the difference the core and true cut? These all is similar.
What?
Core biopsy and true cut biopsy.
Yeah, same thing. I think. Okay.
Yeah. Thank you.
Okay, so we are done with the pathology and now start the pharmacology. Simple thing, you guys already know that very well. Okay, you have the hypothalamus, this is GnRH, act on the pituitary to release the LH and FSH. LH and FSH act on the ovaries, act on the testes to release the testosterone and then to the estrogens. Similarly, in case of females, first testosterone or the androstenediones and then the estradiol, right? You know that HPO axis already. Now, certain drugs can work on this GnRH, and these are the GnRH analogs. Okay. Now, by working as a GnRH analogs, they will cause a continuous release of the GnRH. And I told you, whenever you have a continuous release of the GnRH, you will have a suppression of the HPO axis.
Yeah.
And that's exactly how the leuprolide and the goserelin works. Okay, these are GnRH analogs. They will cause a continuous release of GnRH, and as a result, suppression of the HPO axis occurs. Okay, HPG axis or HP axis, whatever you want to say, right? Second thing, you have the clomiphene, and clomiphene is a drug that blocks the receptors for the estrogen. And I told you that estrogen gives a negative feedback there, right?
Yeah.
So by blocking the receptors of estrogen, I'm increasing the release of GnRH, right?
Right.
So this clomiphene is basically a activator of this GnRH. It will cause a more versatile release of the GnRH, and so there's more estrogen, more testosterone will be released. And that's why this clomiphene always used as a ovulation induction pill. Remember in the PCOS I told you?
Yes.
Good. Now you have the degarelix, which is basically an inhibitor of the GnRH. Okay, it is a GnRH antagonist, total antagonist it is. Okay. Then you have the drugs like the OCPs that works on the ovary, danazol that works on the ovary again. Okay. Give me a second. Yeah. This danazol is actually a synthetic androgen, okay, and that acts as a partial agonist on the receptors. And I told you the function of partial agonist already, right? In the presence of no agonist, it will cause it will work as an agonist. In the presence of a full agonist, it will work as an antagonist, right?
Yes.
So danazol, which is a partial agonist, and again the OCPs you have that contains the the progesterone and the estrogens, right? Then you have the drugs that blocks the secretion of the androgens, and these are the ketoconazole and the danazol again, because in presence of full agonist, that means the testosterone, it will work as an antagonist, right?
Yes.
So ketoconazole, danazol will block the synthesis of the androgens. You have the drugs which will block the conversion of androgens into the estrogen, and these are the aromatase blockers, and they all have the zole in them, tetrozole, okay, the anastrozole, letrozoles, okay. Then you have the receptor blockers, and the receptor blockers are we'll discuss that later, don't worry. Sorry, you have some receptor demodulators of the receptors, right? And you call it the SERM, okay, the selective estrogen receptor modulators, and these are the tamoxifen and the raloxifene. The tamoxifen will be agonist at where? Does anyone remember?
Uterus.
Uterus and bones, right? So
Yeah.
tamoxifen will be acting as an agonist on the uterus and the bone, and as an antagonist on the breast. While the raloxifene is an antagonist on the uterus as well as the breast, and agonist on the bone. Okay.
Yeah.
For the osteoporosis, you will always give the patient raloxifene. For the breast cancer, you will give the patient tamoxifen. Okay.
Yes.
In the males, you have the testosterone synthesis inhibitors. These are the ketoconazole and the spironolactone. You have the 5-alpha inhibitors that are the finasteride. You have the receptor blockers. These are the flutamide, okay, sapropteron, and the spironolactone. I told you spironolactone work as both synthesis inhibitors as well as the receptor inhibitors, right?
Right.
So these are the overview that all the drugs you're going to study later now. And yeah, that's everything. Okay, so first you have the goserelin and the leuprolide. I told you they are the GnRH analogs. They will cause a continuous release of the GnRH, and as a result suppresses the HPO axis. Initially, when you give these drugs, you will initially have an acute flare of the release of LH and FSH, right? At a very
Right.
initial. Okay, at a very initial, because it causes a sudden increase in the release of GnRH. This will cause a release of LH and FSH initially. But when the continuous release of GnRH happens, it will suppresses the HPO axis. Okay, so to prevent this acute flare, you will always give this drug with other receptor inhibitors, like the flutamide. Okay, so you always give a combination therapy of the leuprolide with the flutamide, okay,
Okay.
to prevent this acute flare. You can use these drugs for the fibroids, for the endometriosis, for the precocious puberty, for the prostate cancers, for the infertility. Adverse effects, they can cause the hypogonadism, of course, because they are suppressing the LH and FSH. Because of loss of testosterone, they can cause a loss of libido. Erectile dysfunction can also happen. Nausea, vomiting are the other side effects. Because of loss of estrogen, patient can also have a osteoporosis. Simple thing. I doubt.
No, thank you.
Okay, then you have the degarelix, which is basically a inhibitor of the GnRH. It is used for the prostate cancer because in the prostate cancer, I require the DST, right, to cause the cancer. So by inhibiting the DST, which is could be achieved by inhibiting the LH and FSH. So I give the patient degarelix also. Side effects include the hot flashes and the liver toxicity. This drug is hepatotoxic. And no starter flare is there because it cannot increase the GnRH, right?
Right.
So a solo drug always. Then you have the different form of estrogens, estradiol, the DES, and the mastrenol, right? And they basically bind to the estrogen receptors, causing the agonist effects. Whenever a patient is having a history of hypogonadism, a female patient having an ovarian failure, you can give the patient estrogen replacement therapies. Okay, after patient is having any menstrual abnormalities like the PCOS, for example, you can give this patient OCPs or the insulin therapies, right? A combined OCP will be given. Hormonal replacement therapies could be given in the post-menopausal females. That includes the estrogen again. If you give the patient estrogen, this will increase the risk of patient having an endometrial cancer because it causes the endometrial hyperplasia, right? Yeah. Similarly, DES will increase the risk of having adenocarcinoma. If a patient is having a ER positive breast cancer, you cannot give the patient estrogen because it will stimulate the cancer, right?
Right.
Similarly, if the patient is having a history of deep vein thrombosis or a tobacco use in a woman of more than 30, see, whenever you encounter a woman more than 35 years of age and she is having a history of DVT and tobacco use, you cannot give these patients estrogen because they will increase the risk of thrombosis, okay?
Yes.
So whenever you encounter a patient having an age of 35 years and she is asking you for a replacement therapy or for a OCP, you will first need to take the history of the patient for the DVT, for the tobacco use, and for the breast cancer. Only if she is having negative of all those three, then only you can give the patient estrogen replacement therapy. Otherwise, you will deny them, right?
Right.
While less than 35 years of age, you do not require these the DVT and the tobacco use history, okay? You just require the breast cancer history. Okay?
Yeah.
So that was about the estrogens. Then you have the SERMs or the selective estrogen receptor modulators. These first include the clomiphene, which is basically a receptor blocker in the hypothalamus. So basically the negative feedback of the estrogen will be suppressed. As a result, you will be having an increased release of GnRH and has the LH and FSH. This drug will be used to induce the ovulation, doesn't matter the causes. Whenever you encounter a patient having a history of anovulation or having a history of infertility, and you're not sure by what reason the patient is having infertility, you will always give them the clomiphene, okay?
Yeah.
So when the no reason of the infertility is given, you will always give the patient clomiphene, okay? Again, the patient can have a hot flashes, ovarian enlargement because of the hyperplasia, okay? Multiple simultaneous pregnancies can also happen because of that, because of multiple ovulations, or visual disturbances can also happen, okay? Then you have the tamoxifen. I told you the function of this drug: antagonist at breast, agonist at bone and uterus. You will give this drug for the treatment of breast cancer, but it can cause the endometrial cancer also as a side effect, right?
Right.
Similarly, you have the drug which is a raloxifene, which is antagonist at breast and uterus, but agonist as a bone. Whenever you encounter a patient having a history of osteoporosis and you want to give them a drug, you will give them the raloxifene, okay? Because it has no increased risk of endometrial cancer, okay? Well, as a side effect of these drugs, apart from the endometrial cancer, in case of tamoxifen, patient can has a history of hot flashes, venous thromboembolism. So whenever the patient is having a history of, again, tobacco use or a DVT, you cannot give these drugs again because this will put a patient or an increased risk of DVT, right?
Right.
So for the both of these drugs, you will be having a hot flashes and venous thromboembolism as a side effect. Okay, and these drugs for the activation requires a cytochrome P450. So if you are a patient who is on a cytochrome P450 inhibitor therapy, that will lead to the treatment failure with these drugs, okay?
Right.
Because these are the prodrugs and they need to be converted into the activated form, and that would be done by the cytochrome P450. So if you give the patient inhibitor of the cytochrome P450, then you will have a treatment failure with these drugs. Then you have the aromatase, okay, and the aromatase belongs to a P450 family, okay?
Yes.
Very important to note. So you have the aromatase inhibitors, and they are again P450 inhibitors, okay? These are the anastrozole, latrozoles, and the exemestane, okay? Exemestane it is, right? So mechanism, again, it will inhibit the peripheral conversion of the androgens into the estrogens, right? So use will be the ER positive breast cancer, because for the ER positive breast cancer, you require the estrogens, right?
Right.
And please note, because they're only inhibiting the peripheral conversion, if the patient is having the release of estrogen from the ovary, it cannot suppress it, right? They can only suppress the peripheral conversion of the androgens into the estrogen. That means via the adipose tissue only. Okay, they have no action on the ovaries. Okay, so
Yes.
ovaries can still produce the estrogen. So if you give these drugs to a premenopausal female and you inhibit the conversion of androgens into the estrogens via peripheral mechanism, then you will have the increased release of estrogen from the ovary, right?
Right.
And as a result, these drugs won't work in the premenopausal female. In the premenopausal female, you will always give the patient tamoxifen, while in the postmenopausal female, to treat a breast cancer, you will give the patient aromatase, because the peripheral conversion of estrogen is the only means by which the patient can have a ER positive breast cancer, right? Estrogens.
Right.
So please note, these aromatase inhibitors are only would be given in the postmenopausal women, not in the premenopausals. Any doubt?
No, thank you.
Okay, Ani.
Why
Yeah.
is the aromatase inhibitor not working in premenopausals? I missed it. My cut.
You have two ways by which you can produce a estrogen. One is by the ovary, and second is by the adipose tissue, right?
Yes.
If I give the patient these inhibitors in the premenopausal females, it will block the peripheral conversion of my these androgens into estrogens, right? That means by the adipose tissue. But my ovaries can still form these tissues, right? Sorry, but the ovaries can still form the estrogens, right?
Yes.
So even if you give the blockers, the ovary can still forming the estrogen, that will increase the formation of estrogen because of a negative feedback. If you have a drop in the level of estrogen because of this inhibition, then it will increase the conversion of estrogen by the ovaries. So that won't help the patient, right?
Yeah.
So that's why these drugs can only be worked in the postmenopausal females, when they are not converting the estrogens via the ovary.
Okay. Thank you.
Okay, so any more doubt on this page?
No, thank you.
Okay, now you have the hormonal replacement therapies. For the estrogens, we have discussed that already. You will give the hormonal replacement therapies whenever you encounter a postmenopausal female having a history of osteoporosis, maybe having a history of the hot flashes, maybe, right? Or having a history of vaginal atrophy. So in order to treat these conditions, osteoporosis, vaginal atrophy, hot flashes, you will put a patient on the hormonal replacement therapy, right?
Yeah.
If you give the patient just the estrogen replacement, then it will cause the endometrial hyperplasia, and that will again can cause the endometrial cancer, right?
Yes.
To prevent that condition, you will always combine the estrogens with the progesterone also. Okay, so you will give the patient estrogen replacement therapies as well as the progestins. Okay, and the progestins are the most commonly you will use the levonorgestrel, okay, or you can use the methoxyprogesterone also, or etonogestrel could be given, norethindrone could be given, okay, and the megestrol could be given. So all of them has the gestrone in their name, or a gestrel in their name, right? So gestrel, gestrol, and gestrone. Okay.
Yeah.
So remember, you can just remember these names by just remembering the gestrels, gestrones, and the gestrol. So gestrels are the levonorgestrels and the etonogestrel. Gestrones are the methoxyprogesterones. Gestrol is the Megestrol. Okay.
Yes.
Okay. Now, mechanism will be to bind the receptors on the progesterone receptors, and as a result, this will decrease the growth of the endometrium. It will increase the vascularization of the endometrium. Remember the spiral arteries?
Yeah.
They are
Yeah.
formed by the progesterones, right? So they will decrease the growth and they will increase the vascularization of the endometrium. They will increase the mucus secretions by the cervix, right?
Right.
And that
Yes.
will block the sperm entry again. So they will also help in the conception prevention, right?
Okay.
So they will be used as a method of contraceptions in the OCPs. They will use to prevent the endometrial cancers. They will use to prevent the abnormal uterine bleedings. Okay. Progestin challenge. You remember this challenge? I told you Asherman syndrome, right?
Yeah.
If you have anatomical damage, you won't have any bleeding, any withdrawal bleeding. But if everything is normal, HPX is normal, anatomical barrier is not there, then you will have a normal withdrawal bleeding, right?
Okay.
So a progestin challenge can also be given to the patient. Any doubt?
No.
Now you also have to remember the use of this drug, the Megestrol, which is basically to treat the malignancy-related anorexia. Remember the anorexia and the malignancy?
Yeah.
Cachexia?
Okay, so yeah, cachexia, anorexia, yeah, same thing, right? Anorexia is just when you don't want to eat the food, right? See, whenever you ill, you have this hatred against the food, right? Right? See, whenever you become ill, whenever you have some kind of inflammation, you always see that you become you will develop a hatred from that food, right?
Okay.
So to prevent this condition, you will give the patient Megestrol, okay, to treat the malignancy related anorexia where the patient does not want to eat the food. Okay, so to make them eat the food, Megestrol. Okay,
Okay.
then you have the inhibitors of the progesterones, and these are the mifepristones, okay, or the ulipristal. And by inhibiting receptors of the progesterone, can I increase the contractions in the uterus?
Yeah.
And can it cause the termination of the pregnancy?
Yes.
So these drugs are often used for the termination of the pregnancy. Mifepristone will always combine with the misoprostol, because both the drugs, this mifepristone will prevent the relaxation of the smooth muscles, and the misoprostol will cause the contractions of the smooth muscles, right?
Yes.
Right.
So these drugs are often combined to cause the MTP. Okay, and the ulipristal will also be given as an emergency contraception after the sexual intercourse. Okay, to prevent the pregnancy, you can give the patient ulipristal.
Okay. Because it's an anti-progestin, would it be doing the opposite of the progestin? So it would be like decreasing vascularization and whatnot?
Yeah, all things. Yeah, exactly.
Okay.
All things. A total opposite effect of the progesterone will be seen. Okay.
Okay.
Then you have the combined contraceptions, which are the OCPs that contain both the estrogens as well as the progesterone. Estrogens, because just like in the PCOS, if you have a chronically high level of estrogens, this will prevent the ovulation, right?
Yes.
So because of the estrogen pills, because of high level of estrogens, this will prevent the estrogen surge, and as a result, the LH and the FSH surge. Okay, and if the surge is not there, you won't get any ovulation, and that's how this become a method of contraception, right?
Yeah.
Yeah.
Second thing, because you're also giving the progesterone to the patient, this will again prevent the entry of sperms.
Yeah.
Yes.
So two benefits. One is basically no ovulation, and second is basically the prevention of entry of these sperms. So by these two means, they're working as a very good the methods of the contraception. Now, the progesterone will also be combined with the estrogen by one more purpose, which is to prevent the endometrial hyperplasia, right? To prevent the cancers.
Yeah.
And if you guys go back to the GIT, I told you the patients on the OCPs, they can have a hepatic adenocarcinomas, right? Adenomas, not adenocarcinomas.
Yeah.
Hepatic adenomas, remember?
Yes.
Yeah.
So these patients can have as a side effect, these patients can have a hepatic adenomas. The patient can also have the deep vein thrombosis. Okay, thromboembolism can happen. Breakthrough menstrual bleeding can also be happen sometimes. And if the patient is having a smoking history, she's more than 35 years of age, having a smoking history, having a history of DVT, you cannot prescribe these drugs to these patients, okay? Yeah, very important. If you give the patient OCPs, that means the estrogen, this will increase the steroid hormone binding globulin, right?
Yes.
This will lower the level of free testosterone.
Okay.
And that's why these drugs are very much helpful in the PCOS also, to prevent the hirsutism, right?
Yeah.
So that's, and again, other side effects include the coronary artery disease can also happen, stroke can happen, migraine can happen, especially with the auras. Breast cancer, again, if it is ER positive, you cannot give these drugs to the patient. Liver disease can also be happen. So these are all the side effects of the patient on the OCPs. Any doubt?
Is the breakthrough menstrual bleeding a true period, or is it just spotting?
At a very initial stage, you can have this breakthrough menstrual bleeding, or as soon as you stop these drugs, you can again have these breakthrough bleedings.
Okay, thank you.
Now comes the copper intrauterine device. Okay, and this is again a very most, and please note, Stephen will ask you what is the most effective method of contraception. So you will answer the copper intrauterine device. It is the most effective emergency contraception. Okay, it basically creates a local toxic environment to the sperms. Okay, it creates a local inflammatory site, a reaction that become a very toxic to the sperms. Okay, and this will cause the damage to the sperms, and as a result, the fertilization cannot happen, and as a result, zygote formation cannot happen. Okay, but although they are very best method for the contraception, they will also have an increased risk of getting a PID with the insertion. Okay, so patient will be at an increased risk of getting a PID at the time of insertion. Okay, so they are the long-acting reversible contraceptions. If you remove the copper T, then you will have a reversal of the symptoms back again, right? The cycles will be revert back to the normal again. So that's why the most effective emergency contraception. Any doubt?
No, thank you.
Okay, now you have the tocolytics, and the function of tocolytics is to cause a relaxation in the uterus. So every smooth muscle relaxing agent, that means a calcium channel blockers or maybe an alpha antagonist, right? Maybe NSAIDs, which are the prostaglandin inhibitors, right? The beta-2 agonist, they all can cause a smooth muscle relaxations, right?
Right.
Yes.
So they all will be act as a tocolytic. So the terbutaline, which is a beta-2 agonist, and nifedipine, which is a calcium channel blocker, endomethacin, the NSAIDs, they will all cause a relaxation in the uterus. So this will decrease the contractions of the uterus in the time of labor, right? So this will allow the shifting of the patient from one hospital to another hospital. Okay, if the proper facilities are not available in one hospital and the patient is already in the labor, you will give the patient these drugs. So this will help the patient to transfer to a better location, right?
Yes.
So that is the use of these drugs. Second thing, you can give these patients, whenever you are having a premature delivery, then along with the administration of these steroids in order to cause a lung maturation, you will also give the patient tocolytics to decrease the delivery time. Okay.
Yeah.
So this will prevent again the premature immaturity of the lung, right? The NRDS, remember?
Yes.
So to prevent the NRDS, you will give the patient steroids, and along with the steroids, you will also give the patient tocolytics. The important therapy is the steroids. If the step one asks you to choose one, you will choose the steroids first, because these are the most important things. After the steroids only, you will give the patient tocolytics, so that more maturation of the lungs can happen, right?
Yeah.
Any doubt on this page?
No, thank you.
Now you have the danazol, and I told you this danazol is basically a partial agonist on the receptors of the androgen. And I told you this condition, this drug will be useful for the hereditary angioedema. Remember?
Yeah.
In the immunology, we have discussed about this hereditary angioedema,
Yes.
right? So danazol will be used as a therapy for the hereditary angioedema. This condition would be also be useful for the endometriosis. Okay. So yeah, just like the effects of the androgens, patient can have a weight gain, edema can happen, acne can happen, hirsutism can happen, masculization can happen, low level of LDL, the HDL will be seen, hepatotoxicity can happen. And remember the female TOAD, TOAD, for the intracranial hypertension?
Yeah.
right? So T for tetracycline,
Tetracyclines,
O for
OCPs.
OCPs, A for vitamin A,
Yeah.
and D for danazol, right? So these drugs can cause the idiopathic intracranial hypertension again, right? Blurring of the vision, headache, papillary edema will be seen, right?
Is that the same thing as
Yeah, pseudotumor cerebri. Yes, same thing. Okay. Then you have the testosterone replacement therapies, and these are again the testosterones and the methyl testosterones. Okay, they will be acting as an agonist and the androgen receptors, and basically they will be abused by the athletes and by the weightlifters, right? To enhance the performance, right?
Okay.
Yes. Okay. Other use, important use is to treat the hypogonadism. If the male is having the hypogonadism, you will give them the testosterone, right? To get a normal erectile function, to get a normal libido, to get a normal secondary sexual characteristics, right? You require testosterone for that. Okay. So to treat the hypogonadism, you will give the patient testosterone to stimulate the anabolism. Okay. To promote the recovery after the burn, you will give the patient testosterone. For the performance enhancement, these steroids could be abused by the athletes. Okay.
Yeah.
Now the side effects we have discussed previously. Remember the skin side effects, you will get the acne, you will get the oily skin. For the CVS, you will get the you will get the high level of LDL, low level of HDL, high level of hematocrit, remember?
Yeah.
These are just all the testosterone effects, right?
Right? Yeah. What?
Nothing. I'm sorry. I misheard something. I'm good. Thank you. Sorry.
So the patient will be having an increased number of the erythrocytosis will happen, increased hematocrit will be there, venous thromboembolism risk will be increased whenever you give the patient this therapy. Okay, so whenever you encounter a patient having a prostate cancer, you cannot give the patient testosterone therapy, right?
Yeah.
When the hematocrit reaches more than 50%, you cannot give the patient testosterone therapy because again, it will cause a rise in the level of RBCs. If the patient is having a severe obstructive sleep apnea, these drugs are again contraindicated because they will increase the level of LDLs. They will make the patient more obese, right?
Okay. Yeah.
So again, you cannot give the patient who is having an obstructive sleep apnea. That will cause a worsening of the symptoms. Okay. So that was about the adverse effects of the testosterone or the methyl testosterone. Any doubt?
No, thank you.
Again, the patient will also become infertile, remember?
Yes.
Note that also. Now some anti-androgen drugs. First one is the finasteride, which is a 5-alpha hydroxylase inhibitor. It will decrease the conversion of testosterone into the dihydrotestosterone. So it will be useful for the BPH in the patient, right? And adverse effects include the gynecomastia because the remaining of the testosterone will be converted into the estrogens, right? So this will cause the gynecomastia. Sexual dysfunction can also occur because in case of a normal sexual function, you require the DST, right?
Yeah.
So sexual dysfunction and the gynecomastia are the side effects of a patient on the finasteride therapy. Again, because the dihydrotestosterone is responsible for the male pattern baldness, right?
Yeah.
So by giving the patient finasteride, you will be also be helpful in treating the male pattern baldness. So two uses, BPH and the male pattern baldness. Second is the flutamide or any other drug which is having tamide in it. Okay, the flutamide, baculotamide, aplutamide, right? So all of them has a tamide in it or lutamide in it, right?
Yeah.
So these are the, again, the competitive inhibitors at the receptors of the androgens. They are most commonly combined with the leuprolide, right? Whenever you give a patient leuprolide therapy, as an initial therapy, you will combine these two drugs, right? To prevent the acute flare, right?
Right.
And where you give the leuprolide to treat the prostate cancer.
Yeah.
So for therapy of the prostate cancer, you will give the patient leuprolide and the baculotamide or the flutamide, right? And so this will be to prevent the acute flare. Then you have the receptor blockers, and these are the ketoconazole and spironolactone. Okay, again, the spironolactone is both the synthesis inhibitor as well as the receptor blocker, remember?
Yes.
And these two drugs will be useful in the PCOS patient to prevent the hirsutism, right? But both the drugs can cause the gynecomastia and the amenorrhea. Ask. Any doubt?
No.
Okay.
Will it have the diuretic side effects also or not?
Of course, it will have. Spironolactone will have the direct side effects also, right? It will cause a loss of the sodium. It will cause a reabsorption of the potassium. The loss of bicarbonate will be there, right? So all the side effects that you know from the renal chapter will be there in the spironolactone. Okay.
Okay. Thanks.
Other important drug, which is a receptor inhibitor, which is a cyproterone, which is not mentioned in the first aid, so you can write it down. So cyproterone, spironolactone, ketoconazole, these are all the receptor inhibitors. Spironolactone is both a receptor inhibitor as well as a synthesis inhibitor. Okay. Sorry, the ketoconazole is a synthesis inhibitor, not a receptor inhibitor. Okay.
Yeah.
Ketoconazole is a synthesis inhibitor. Okay. Spironolactone is a synthesis inhibitor, and this cyproterone is a receptor inhibitor. Okay, these are both. Spironolactone is both receptor as well as the synthesis inhibitor. Okay, and they basically inhibit the synthesis by inhibiting the 17 alpha hydroxylase. Remember, in the endocrine we have discussed 17, 11, and 21 alpha hydroxylase.
Yeah.
So by inhibiting the 17 alpha hydroxylase, I cannot have the conversion of my the cholesterol into the androgens, right?
Right.
So that's how they will prevent the formation. Then you have a drug which is a tamsulosin, and again the alpha-leucin, okay, the prazosin, trazocin, they are all the alpha-1 antagonists. We have discussed that already, right? And they are the selective alpha-1 AD inhibitor. Okay, they are found, and these receptors are found on the prostate, while the receptors, the alpha-1B, they are found on the blood vessels. So the drugs like the prazosin, trazocins, they are basically inhibiting both the alpha-1B as well as alpha-1A, while the tamsulosin is inhibiting only the alpha-1A. Okay.
Yes.
And the final drug is the minoxidil, which is a potassium channel opener, and this drug is useful for the treating the baldness. Okay, it will cause a vasodilation, increasing the blood flow to the head, to the hairs. That will cause an increased growth of the hairs. Okay, so it will be useful for the treatment of androgenic alopecia, but it can again cause a hypotension. So it will so this drug will be also be useful for the severe refractory hypertension because it is causing the vasodilation, right?
Yeah.
Okay,
So superficial
so that's
use
about,
also,
yeah.
the topical use also cause vasodilations, and
The topical use is basically for the baldness, and the systemic use is for the hypertension. Okay.
yeah. Okay, thank you.
Okay. Yeah. So any more doubt?
No, thank you.
Okay. So let's wind up here. Okay. And from tomorrow we'll discuss the respiratory.
Yes.
Yeah, thank you.
Thank you so much.
Okay.